for a conference on Udaipur Multidisciplinary Cancer Summit 2026, Integrating Specialties, Improving Outcomes. And with immense pleasure, I would like to invite the program convener, Dr. Ankit Agarwal, who is consultant medical oncologist at Gitanjali Medical College and Hospital, Udaipur, for the welcome and introductory note. Over to you, sir.
Thank you, and I'm very grateful that we could be here on a Monday evening, and special thanks to uh, all our colleagues, panelists, moderators, and who have taken out time to be here on after a busy Monday. And I think we look forward to a good discussion. Look forward to having a good discussion on the recent topic so that we can plan to change our treatment guidelines as per the recent changes. So I think without wasting further time, I'll call upon Dr. Rohit for his first talk, and the next talk he'll be taking a lecture on. Rohit, am I audible? Okay. So Dr. Rohit is a senior medical oncologist at Zydus Cancer Hospital in Ahmedabad. He'll be discussing about the optimizing biomarker testing in metastatic breast cancer with special emphasis on ESR mutant metastatic breast cancer. Over to you, Dr. Rohit. I think we'll start now. Rohit,
thank you, sir.
Over to you. Thank you.
Let me share my screen first. Okay, is my screen visible and am I audible?
Yes, sir.
Yeah,
absolutely.
Okay. Thank you. At the onset, I would like to thank Ankit Agarwal, sir, for inviting me and making me the first speaker for this conference. Me and Ankit, sir, have been colleagues in Udaipur for quite some time before I shifted to Ahmedabad. So let me get started with this. Optimizing biomarker testing in metastatic breast cancer, ERPR HER2, HER2 low, ESR1, PIK3CA, and beyond. So the traditional view of HER2 positive breast cancer is tumors lacking this HER2 expression or amplification. These tumors were classically defined as being HER2 negative if they did not have the expression of HER2. HER2 constituted only about 20% of the total pie, and hence it's a very restrictive subset of patients that we consider to be HER2 and that could be treated with anti-HER2 antibodies. So the amplified ERBB2 amplified with benefit from the therapeutic pathway of HER2 was proven in the Destiny Breast 01 study with the TDXD. But now we wanted to see if this particular pathway could also be used in the HER2 low category of patients. And that's why the Destiny Breast 04 study came, where the non-amplified without benefit from HER2 inhibition could be targeted with novel ADCs, because ADCs worked with a different mechanism of action. Hence, by giving ADCs, we could, even target these patients who had HER2 low expression. So this basically brought into the picture the classification of HER2 positive breast cancer, where HER0 was where there was no staining observed, incompletely or faintly or barely perceptible in less than 10% of the tumor cells. Score 1 was incomplete membrane staining, but in more than 10%, and score 2 was weak to moderate, complete membrane staining observed in more than 10% of the population. So this is what 1+ and 2+ meant. And in 3+, obviously, we know that the circumferential membrane staining is complete and intense in more than 10% of the population. In HER2 positive, we were always using anti-HER2 therapies like TDM1 and also trastuzumab, pertuzumab, etc. But there was no approved anti-HER2 agent in this 2+, 1+ or 0 classification till about 2021. So the definition of HER2 low breast cancer, the static definition was IHC 3+ was considered to be HER2 positive, 2+ if they turned ISH positive was considered to be HER2 positive, everything else was considered to be HER2 negative. So if you look at it, only 15% of the patients actually would be classified as being HER2 positive breast cancers, whereas about 55% of the patients came into this low. So if you consider both of them, you see about 70-80% of the patients actually falling into the category of HER2 positive and HER2 low breast cancer. So that opens up the therapeutic armamentarium quite drastically. So this definition is quite dynamic. It changes over time. So whenever you're planning to use any sort of anti-HER2 therapy, it's always better to get a fresh biopsy tested at progression and check at that particular time point if the patient is actually HER2 expressing or not. So the phase 2 DAISY study showed that best overall response rates as per the HER2 status. And one can see that definitely, when you look at HER2 3+, the response rates are about 70%. And the waterfall plot is extremely beautiful, with very few progressive disease and most patients responding, at least with a partial response, and even more having quite good or beyond partial response. Some even attaining complete responses. But you might not see such a beautiful waterfall plot with the HER2 low, where the overall response rates were around 37.5%. And in the hormone negative group, there were some progressions that we see, which were not as significant in the hormone positive group. In IHC 0 group, also the waterfall plot is not as beautiful as the one we see with the IHC 3+, but definitely you're seeing responses. So the median duration of response was also about 6.8 months and the PFS of about 4.2 months. So the BREAST 06 is the study that tested TEXT in chemotherapy naive and HER2 ultra-low advanced metastatic breast cancer. It is a randomized open-label phase 3 study, which was randomized to TDXT and chemotherapy. Patients with advanced metastatic breast cancer with progression on 2 previous endocrine therapies restricted to hormone positive, HER2 low, that is IHC 1+ or 2+, or HER2 ultra low, that IHC more than 0 but less than 1+, based on central IHC assessment at diagnosis. And this happens to be very important because there is always this possibility that it's not properly identified. So we need to always be sure, get a second opinion if we are not sure whether this IHC staining is properly done or not. And considering that a lot of institutes now are trying to do everything in-house, sometimes it's always better to take an external opinion in situations when we are using these expensive drugs. So they were then randomized to TDXT versus chemotherapy, with the primary endpoint being PFS and the secondary endpoint being OS in the IHC 1+, 2+ population. So what you can see is in the Destiny Breast 06, we have increased the targetability with ADCs, and it's a continuous spectrum of HER2 low expression also. So the ultra lows constitute very, very small percentage of the population. So the treatment pathway for hormone positive HER2 negative breast cancer basically includes multiple factors downstream. The targetable ones happen to be the PIK3 pathway as well as the mTOR pathway. The CDK4/6 inhibitors has been in the game for quite some time. We have seen a lot of new SERDs come into the market, and the old faithfuls of aromatase inhibitor and ovarian functional suppressions have always existed in the past. So detecting these targetable mutations, the tissue biopsy for comprehensive genomic paneling, they confirm receptor status and metastatic tumor of origin. Liquid biopsy for genomic alterations, and reflex tissue biopsy if ctDNA tumor fraction is less than 1%. So this is how we analyze for this particular situation. So when we detect targetable mutations in HR positive, HER2 negative, we find that the genomic alterations commonly identified in the first line, in tissue biopsy, they are about 58.8%, and in liquid biopsy, about 42.7%. Increase in the GA rates are seen in later lines of therapy, detected at 62 to 71% incidences, mainly due to acquisition of the ESR1 mutation. Tissue biopsy is more sensitive than liquid biopsy for detection of the PTEN loss. Alteration in the PIK3, AKT, PTEN pathways occur in 40% of patients with hormone receptor positive breast cancer. Majority of the mutations are seen in the PIK3CA pathway. PIK3CA mutations do not predict response to CDK4 inhibitors. They are less common mutations. AKT1 is seen in about 2 to 3%, and PIK3 regulatory subunit alpha loss of function mutations in PTEN are seen in 2 to 4% of the population. So the ESR1 mutations are basically dependent on time of testing. They occur in 40 to 50% of the patients who have previously been exposed to aromatase inhibitor. Less than 1% of patients actually who are treatment naive will have this particular mutation. 4 to 5% of patients who receive adjuvant AI will have this particular mutation. And 50% of patients after 1 year of first-line CDK4/6 plus aromatase inhibitor will eventually land up developing this mutation. So it's very rarely seen in a treatment-naive patient, but it's something that we commonly see in patients who are on the later lines of therapy. and they tend to develop 3 to 6 months before radiological progression on the aromatase inhibitor. Their consequence is it's associated with poor response to AI and with shorter PFS and 1-year OS. So obviously we need to treat these ESR1 mutations differently, but definitely these are mutations that tend to get acquired as the patient is being exposed to the aromatase inhibitor. So when oral elacestrant was compared to standard of care fulvestrant in postmenopausal breast cancer patients in second or subsequent line hormone positive, HER2 negative metastatic or advanced breast cancer, the results was that ESR mutation rate was about 50%. The progression-free survival in the ESR mutant patients, in all patients, was about 2.8 versus 1.9 months. But in the ESR mutant patients, you see it is 3.8 versus 1.9 months. Impact of duration of prior endocrine therapy plus CDK4/6 inhibitor on progression-free survival. Those with at least 1 year as surrogate marker for endocrine sensitivity had a marked improvement in progression-free survival. The PADA-1 trial required ctDNA monitoring for acquired ESR1 mutation, where AI plus palbociclib versus fulvestrant plus palbociclib was used. The tested clinical utility of real-time ESR1 mutation detection at baseline, 1 month, and then every 2 months. Patients with rising ESR1 mutation via ctDNA with first-line AI plus palbociclib were randomized in a second step to stay on AI plus palbociclib or switch to fulvestrant plus palbociclib. ESR1 mutation at baseline was 2.1%. With patients in prior AI exposure was 4.9%. Patients with ESR1 mutation had benefit in median PFS when switched to fulvestrant or palbociclib, and the PFS was 11.9 versus 5.7 months. The SERENA-6 study, they used oral SERDs plus CDK4/6 inhibitor versus AI plus CDK4/6 inhibitor. The goal was to detect molecular marker of treatment resistance. Patients with hormone positive, HER2 negative advanced breast cancer to utilize real-time prospective liquid biopsy monitoring with ctDNA. The ctDNA screen for ESR1 mutation every 2 to 3 treatment cycles. Switch patients to next generation SERDs when the target mechanism. Switch patients to next generation SERD that target the resistance mechanism at the time of detection. Assess efficacy and safety of switching patients who have acquired ESR1 mutation and without clinical disease progression to camizestrant plus CDK4/6 inhibitor versus continuing AI plus CDK4/6 inhibitor. The result was improved PFS when switching to camizestrant plus CDK4/6 inhibitor with no new safety concerns. Discontinuation were low and similar in both arms, and the final results of this particular study are pending. However, whether switching to a second-line treatment in patients who do not have radiological progression is something that we need to question in this particular study. We always need to look for patients who actually achieve a radiological progression before shifting, as this is basically trying to introduce a second-line treatment early. So the actionable biomarkers are hormone receptor positive, HER2 negative metastatic breast cancer. The biomarkers are PIK3CA activating mutations, which can be detected by NGS or PCR, where the FDA-approved agents are ivanolizumab plus palbociclib plus fulvestrant, especially in those patients who are endocrine resistant, alpelisib plus fulvestrant. The PIK3CA or AKT1 activating mutations of E10 alterations, these also are tested using NGS and PCR, where capivasertib plus fulvestrant is approved. The ESR mutation, where NGS and PCR using ctDNA is preferred, where elacestrant is approved. So the key concepts are latest evidence and clinical implication of
So sorry for the interruption. Request you to conclude your presentation.
Yeah. Okay. Yeah. So thank you. That was my last slide.
Thank you, sir. Thank you. So next.
Thank you, Dr. Rohit. Thanks a lot for a wonderful discussion. I think we'll go to our panel discussion now. Dr. Rohit, we would like you to stay for the panel discussion. We have things for you in house. TP Sahu sir will be moderating our panel discussion. I will also join.
I have one more meeting, sir, right now.
Is it?
So, sir, request you to join kindly. Dr. Rohit Rebello, Ankit Agarwal, sir, and Dr. Ankur Punia is also there. So, Dr. TP Sahu, sir, you can.
Yeah, Rohit, just let me know whenever you want to go. Okay, just tell me.
So, Dr. Preeti and Neha will be joining shortly, sir. They will join.
That's okay. We will start. We just cannot
wait.
wait.
We need to start. Thank you.
Yeah. So Ankur is there. Uh, anyway, I see Ankur. Ankit is there anyway. He is the director. Rohit? No, Rohit has gone. Na? That's fine. So
No,
we'll
sir.
start.
Rohit sir is there. Rohit sir is there. Rohit
Hi,
sir
Rohit.
is unmuted. So,
Rohit is muted. Yes, Rohit is
No,
there,
that's
sir.
okay. So we'll start. We will not waste time. So this is thank you, Ankit, for the invite, and it's always lovely to do panel discussions. You have to learn, read, and you become better. That's how I think education and academics go. So I'll share my slide, and let's discuss and find and see how we can take the things forward. Uh, I'm sharing screen. Okay. Okay. So I think my slides are visible and I'm audible, right?
yes, sir. Yes, sir.
Yeah.
You need to make it full screen. Yeah, it is.
Yeah,
It
it is
is.
all done. So it's
Yes,
all,
sir.
so I'm going forward. Okay. So what I'll do is I first have to, just give me. Pradeep, क्या हुआ? हाँ. So first thing is that I will just go to the Optima. That is, I think, will be the was the most important discussion in breast cancer that happened in ASCO 2026. Then I'll go to time permits to Lidera. And then if there is anything left, we can talk about 2-3 minutes last on Serena. So it is 7:05. We will give back the podium back to the organizers by 7:25:30. So that's what we will do. Okay. So Optima, this is a very clear-cut design. We have seen the key need for chemotherapy and the de-escalation of chemotherapy that has happened. We have seen that happening, and we have seen that happening with Oncotype DX and Mamaprin. So Optima was all about using a Prosigna, which is one more test which is used, a multi-dynamic assay test, which is used actually to look at the benefit of chemotherapy in a select group of patients. So Ankur, if I can come down to you first, this is how the design was. So basically, the patients were around 400 plus. They had to take a consent. One arm was a control, where every patient received a chemotherapy followed by endocrine. And the other arm was test driven directed, which were they all received a Prosigna. Then the risk of recurrence score of more than 60 or less than equal to 60 was taken. And this was randomized to chemo plus endocrine versus endocrine. So little different from how you have seen the Telerex data set actually evolve. Here you already had a control arm with chemo plus endocrine. When the Prosigna was done in the other arm, and then the Prosigna testing done more than 60 and less than 60, they were then randomized to chemo plus endocrine versus endocrine. And this, both the arms were blinded to randomization. So these patients were in control or the high score, they did not know actually. So this is the scheme of things. So anything which you feel is different from what you used to practice till now, Ankur? Let's say the Oncotype DX data, the Mamaprint, what is different in Optima design?
So it takes it a little bit broadly. It
Okay.
just tells us that we did a prosigna. If it's high risk, we'll give chemotherapy. If it's low risk, we're just going to give endocrine therapy and going to compare with the control arm. Taylor X was, I think, was involved more. It answered better whether the low risk actually needed chemo or not, high risk needed chemo or not. It's a little bit broad between the trial design is a little broader. It doesn't
Okay.
actually answers properly that for high risk actually you need chemo or not. It doesn't answers that.
Okay. So, Ankit, anything more you want to say on the design, which is little different from what we have been practicing as of date for such type of assets?
I think so. It looks to me it looks a good design. Um,
Mhm.
High risk going for chemo, low risk going for only endocrine therapy, and you compare it directly with a control arm wherein every patient receives a chemo and blinded to randomization. I think this is what we were looking for.
So,
So
Dr. TP
basically,
Sahu, sir, Dr. Preeti is there. She has joined,
okay.
sir.
Okay. So what I basically find is different is age group. If you remember, most of the trials, Mamaprint and the Oncotype, which had used is around 50 years. So here it has taken down till 40 years. The second is the nodal. Here they have taken a very high nodal disease. We had already taken first the N zeros. Then we came up to 3 nodes, but here they have taken up to 9 nodes. So because basically the N2s also has been taken. So basically they broadened that ambit of what we used to consider that was इस patient को तो करना ही नहीं है, कीमो ही करना है. So they've little bit broadened that ambit actually. So they've taken N2s, although that is only 19%, but still 1/5 of the patient were N2s. And the second they have done is they have reduced the age to around 40 years from 50 years. So this is again two more important than what the other panel spoke about. Number two, this is the statistical design of it. Uh, I just want to just take half a minute and then go to the other questions. So this is a time-driven event. So mind you, most of the trials are event-driven. This is a time-driven. So once the time period is there, 4 years, 5 years, then we are okay with it, and we see the maturity and we release the reports. It is not event-driven. Most of the trials are event-driven. So that is one point. The second point is we do see the IDFS as a primary endpoint in most of the trials. Here it is IBCFS. So anyone in the panel, Preeti, you may take it first and then others. What do you feel the difference between a IDFS and IBCFS? Anyone? Okay, I'll just tell you. It is that they have taken only the breast cancer recurrences. So B is for breast. So for IDFS, it is actually that any infiltrating any disease anywhere in the body. So they have not considered anywhere any cancers to be taken. They have only taken the IBCFS is the breast related events. So this is something that is different from other data sets. Okay. Dr. Preeti, you're there. Ankur, I'll come to you. They have taken Prosigna. That's the PAN. So do you feel they were right enough in doing that? And do we have a correlation, whatever type, between oncotype and a PAN50? I hope you're getting my question. Can we correlate the data set of the risk categorization with oncotype and PAN50? Are you aware of a data set?
I'm not aware of any data sets. All the sets were, developed differently. You can correlate.
So do you feel if someone does a PAM or oncotype or mama print, does it matter?
I more or less I feel it doesn't matter much because all of them were developed, though not prospectively or were not validated, but all were developed independently and have shown results in the various cohort studies.
So interestingly, before the Optima was done, they did something known as Optima Prelim. It was more of a pilot study, and they took the same inclusion criteria which they took for Optima. And I'll tell you, very interesting. I also came to know it last week only, where I was preparing for something else, not for this talk actually. So if you look at it, this is the data set which they wanted to use to validate and look at the Prosigna versus Oncotype. And just look at it. This is the recurrence score for oncotype. That's less than equal to 25, more than 25. That's what the criteria is. If you look at Prosigna, that less than equal to 60 and more than 60 comes, and just look at the low risk. When the oncotype low risk is there less than 25, and Prosigna, if the 60 is the cutoff less than 60, you have a 90% concordance. Means if the risk score is low, both the parameters are looking good. Just look at it when the oncotype is less than 25 and the Prosigna still can be more than 60. There is around 75% patients. So B's basically on the lower score, both are concurrent. And if you look at it at the highest, if you have oncotype risk score of less than 25, you can have a majority of patients who can still have a high Prosigna score of risk score more than 60. So this is something very, very surprising. So my take home for this will be at a lower score, both look very good. But if the risk score is high for one, it necessarily may not mean that it will be high for the other. It may be low for the other. Why? I don't know. This is the data set. And that is why they're looking at less than 60 looks more concordant because they have concordance more at 60. Beyond that, it is actually very, very dicey. So this is the best data set I could pull out, and the investigators of Optima only did this data set. Okay. Ankur, one very simple question. The criticism of Optima, whenever you will listen to our colleagues speaking about it, is that time period and the follow-up is very less. कि 5 साल का ही data है, hormone positive है. Do you think the criticism is valid?
It's up to a point, I will say, because we now know that uh, it doesn't changes much over time. But yes, still 5 years is not that much of a long of a time. It gives us a preliminary idea that
Okay.
yes, it might be same, might change slightly, but not that much. I'll say over time, it has been seen in
Okay.
majority of trials.
Now, two things what I get from you. You would be more satisfied for a longer follow-up because it's hormone positive disease. The second which I get from you, Ankur, is very rightly and very nicely put up. The people remember he spoke about sentence that I don't see that there will be a lot more recurrences after this. But then also I would like to see a longer follow-up to be confirmed that. Ankur, I'm right. That's what you
Yes,
told me.
yes, sir.
And actually is right. So the Taylor X data did tell us that post 5 years to 9 years, the fall was very less. There were lesser recurrences that happened in this period. So you would expect that there would be not a lot more difference. Point one, which Ankur spoke. Number two, if you look at it, this is a very beautiful data set taken from the ASCO discussion slide. Look at the Optima, 5 years. Look at the RX Ponder, again 5 years. Look at the MindAct, again 5 years. Although the endpoints are different, this is a distant metastasis free survival. This is IBCFS, which I spoke about. This is IDFS. The Telerex is the only data set in this sphere which is 9 years follow. So the criticism of time is not that important. Why Optima is criticized, people remember, they have taken a much higher nodal disease status. You would expect little more relapses to start happening, and they probably will not behave like the Taylor X and the RX Ponder. You might be having little more relapses because these data sets had up to 3 nodes, but this is having a data set till 9 nodes. So this is why people are probably not very comfortable. They want this Optima data set to mature more. So I hope I made a very clear point and people are understanding why this criticism of time is coming in. Is Preeti there? Okay. So we'll move on. Ankit, to you.
Yes, sir.
And yeah, and then this is something different. Optima had made mandatory the LHRH agonist or the OFS. And if you see at any new trial for hormone positive disease in early, at least, OFS has become more mandatory. So in your practice, how important is OFS? Do you
So,
practice LHRH agonist? And if yes, what are the patient subgroup where you want to practice a LHRH agonist surely?
so especially for premenopausal, obviously,
It,
and
it, it, it has to be for premenopausal. For what is the length of duration?
so basically, it's the patient who have been given LHRH agonist. It is at least till they become 50 years of age,
Okay.
or if we have blood tests like serum estrogen and estradiol levels and FHS levels turning
That's
out to
fine.
be postmenopausal after 2 years, at least for 2 years of
And
treatment.
you're thinking of 2 years. Last question
Yes.
before I move to Ankur. Do you feel that females which we are giving LHRH agonist, now the practice of LHRH agonist has increased actually in India also? Do you find problems in these patients to agree to take a very prolonged ovarian suppression, medical suppression, or do not complain in your practice?
So only 10% of the people agree to LHRH agonist. If we
Okay,
account for
and
100,
those who you once you started off LHRS agonist, how many of you do you think drop out before the 2, 3, 5 years, whatever you decide to?
a lot. So I think more
A
than
lot.
50% they drop out.
Okay, Ankur, same questions to you, very for specifically for OFS. Do you feel ovarian suppression? It's a big issue convincing the females, and it is also a difficult strategy.
Yes, sir. I feel it's difficult. Not everybody agrees because they have to, take regular injections. People are very, very concerned about that. They want to, just oral therapy is a much easier option.
When the
And the
side effects are
OFS
very bothering, actually. There
and
is a
side effects, I
vaginal
agree, sir.
dryness.
Almost 25% of patients, lesser the age, the higher the number of side effects. So in almost 25% of patient, I have to stop OFS and switch even
Great.
AI or let tamoxifen because of the side effects.
Beautiful. So now this Optima mandated OFS expectedly because they are a very high nodal disease, and we are giving OFS to high nodal disease mainly. So this is very beautiful. And this is people remember this is Telerex. And look at the chemo plus endocrine versus endocrine better. And look at the menopausal patients. And look at the hazards 0.57, 0.54, 0.60. So basically, the addition of chemotherapy did make a difference. That's what I want to say. That's why the 50 years treatment was important. But Optima, suddenly if the benefit of chemotherapy goes away. Hope you're getting my point. The hazards just come to 0.96. Ankur, what could this happen? What could have happened that this is behaving little differently from the others?
Because so sometimes it's considered that chemotherapy actually makes the patient post menopausal,
Beautiful.
so that is giving the benefit
So
rather than the chemotherapy only alone.
beautiful. So what is happening is, and the authors have concluded, even the discussants have put this line. This is something people remember that in our practice we spend so much time on chemotherapy, but the benefit of chemotherapy in younger age, this proves, is predominantly also due to the suppression of the endocrine system. And the chemo pause that happens could be doing it, and once the OFS is being given here, which is mandated for all patients on endocrine therapy, which was not mandated for Mindac, Telerix, or RX Ponder, the benefit suddenly shrinks, further confirming the fact that the in premenopausal, the benefit of OFS probably takes away the benefit of chemotherapy. So this is something very important coming out. It is a hypothesis generating, but a good hypothesis from 0.54, 0.6 is just comes sinces to 0.96. Basically, all benefit of chemotherapy goes off. So Ankur, nicely done. And do you have, Ankur, the concern about the number of nodes? Would you practice tomorrow, do a PAM 50 for a 48 years old, 50 years old female, or maybe 60 years old female who was 6 lymph node positive? Ankur, will you offer this patient based on Optima the option of PAM 50, 6 nodes positive, 60 years old female?
I'm still not convinced for into disease. I will say I will look at other risk factors as well before
Mhm.
deciding whether to just follow blindly PM50.
Back team, if Preeti is there, just tell me yes, because I've called her 2, 3 times. She's not responded, so I'm not able to see her. Ankit, are you convinced? Would you do it?
Um, no, sir, not as of now.
Okay.
It's not very easy to digest that an N2 disease we can omit chemotherapy based on an Optima trial. I think
So basically, Optima has tried to test the science of that biology matters more than the clinical feature matters. So what they have done is they have expanded the gambit with their data set of 3% lesser is okay, more than 3% is not okay. They have proven in within the statistics, ambits of their statistics, that it was good. But remember that why people are fence watching is the number of events that has happened is very, very low. Even till 4, 5 years, only 17 versus 20 events have happened. So people are little concerned. Probably they would like to wait for 9 years or 8 years. If a prolonged follow-up is also showing that 4 to 9 lymph nodes, it really doesn't matter and relapses are not happening, I'm pretty sure most of us will be convinced when the next data set for Optima comes. And if it does not lose the statistical inferiority, I feel then the convincing will happen. I totally agree with Ankur and Ankit. I myself would little be skeptical, especially in younger, but definitely more than 3 nodes in elderly also I'd be little more skeptical. But this data set, if proven right on a longer follow-up, will just tell you that biology is the king in breast cancer, at least in hormone positive. So my concerns is short follow-up. 1/5 of patient in N2, we can be sure. Can we be so sure? I'm not. I don't know. In premenopausal 45, can I let go chemotherapy? Also, I'm not sure. Although what I'm convinced about from Optima is I will definitely go for LHRH agonist. That is something I'm going to push, and that hazards of 0.96 does tell me that chemotherapy is mainly acting to the endocrine suppression. Last question, and probably then we can, if time permits, we'll go to one more, other we'll stop here. Ankur, do you have any idea about deep learning where the pathologist can tell us with AI, help of AI, boss, you don't need to do oncotype, you don't need to do PAM 50 with a pathology report. With the help of AI, they can tell you whether the patient falls into a high risk or low risk for chemotherapy. Any idea?
So yes, sir, I have read about and I've seen the studies, but still I'll say early days we need more data, and to correlation is much more important. Yes, AI can, predict a lot more things which a simple pathologist cannot see. But I'll say early days for this might have a stronger data in the future.
I asked for this in the group 4 5 days back. This paper was shared by someone. It must be in the in a Medom group. People should read this. It's a beautiful paper, which is I agree to Ankur. This is the first step towards a major step. And they looked at the feasibility, and here they have done the AI training with the Oncotype DX cohort. And they found that if the cohort is well trained, the AI is well tuned, and they have taken at least each slide, they have taken at least 200 pictures of the slide. So this is quite a bit of protocol, which don't want to say. The take home here is if I've done the AI done, if the learning is good, just look at the concordance of each subgroup, the actual oncotype versus the pathologist predicting you after the AI learning has happened. It is totally concurrent. So what is totally concordant? What it is telling you is that because the tests are so costly, especially in socioeconomic resource limited setting, if this comes into practice, we can get the same reports probably at 10 20,000. Not have to spend that 70 80 2 lakh 4 lakh rupees. So this is something watch out. And they are also telling that this is more of a approach that they are going to test on a phase 3 randomized trial. And I think that day it is done, this is the approach people are going to accept and will be shifting from the high cost test to something that is AI based. So here is something which I thought was very important for us to know, that AI is also coming into even the prognostic and predictive part of our treatment. So I think I'll stop here. We have come to the thing. Only Ankur, I'll ask you. Lidera is, I just think the design for people who are really interested is nothing but very early cancers, especially node positive. We had a 4,000 patient. Majorly, they are node positive 80%. So these were both pre and post menopausal 40/60. They randomized it to giredestrant, which is a SERD, for 5 years, versus a TAM or AI for 5 years. And they used OFS for all patients who are premenopausal. So again, OFS importance is being done here. The take home is you don't see much of a difference. The exact difference that is happening is around 2.8% at 3 years. So basically, at 3 years, the reduction that is happening of IDF is around 2.5 to 2.8. Exactly the same reduction which Monarchy had at 3 years, 2.8%. Ankur, and the best thing about this trial was the side effects were lesser for giredestrant. So we have a drug that is superior at this point of time. The side effects are much lesser. It is better tolerated than the AI or TAM. Would you offer it to your patient whom you feel this, if once the drug is available, let's say the patient have deep pockets, I'm not talking finances. Do you feel this is practice changing at this point for a patient group?
For this, I not so much, sir, because the problem which I feel with this, surge is that because SERD are like the next step for AI. Some that resistance mechanism happens, and then the SERD works for around 30
So
forty
you
percent of
want to
patients.
give it at a later point of time?
So, no, I want to see the further follow up, especially because what happens to
Okay.
these patients when they progress on SERD? How will they
What will
respond to the next line of therapy? So that's why I need a longer follow up because we don't know how the patient does after SERD. We don't have much data regarding that.
Okay, let's assume a situation. This is a 3 year follow up. At 7 years follow up, the IDFS benefit comes to 7% with a
So
better
we'll have
tolerance.
either or option, either give Abima
Okay.
cycline or Jadistant and give the option to the
Okay.
patient whatever
Fair.
he likes, whatever side
Okay.
effect he doesn't like, we can avoid that drug.
So I'll tell you what is the future. We are getting trials with SERD plus CDK4/6. That's already there in the metastatic setup. We are also going to get it in the settings. So basically, if tomorrow what I'm worried is if this is just the SERD plus CDK4/6 in adjuvant, if this adds to already the CDK4/6 plus AI, and if the IDFS is further widened, means the control arm is the CDK4/6 plus AI, and then the patient is taken the giredestrant plus CDK4/6, and then I get a IDFS benefit. I think that becomes a practice changing, right? Because the toxicities are better, and that is what the future is. So if you remember, SERDs, we started with second line hormone therapy. This ASCO, it has come to front line, although the data set is not great. That is that is something which we will not discuss today in this meeting. And now it is in early adjuvant. So people are telling that for the toxicity, such a beautiful toxicity, people might use it for the patient who have lot of arthralgias and other problems. But all the people are fence sitting. It is only 3 years. They want to have a longer follow-up. Plus, they are thinking of if the CDK4/6 and AI and Z-resistant plus AI, if Z-resistant plus AI is proven superior statistically, then that could be practice changing. So that is something which I thought I could discuss, and that is why I brought this data set. I'm just winding it off. I think if you look at it as my take home, I will just tell you Optima for me is practice changing. Needs longer follow-up, very sure, especially because they've used a much higher risk group of till 9 nodes. So probably 3, 4 years more, 8 to 9 years follow-up. And if this data stands, I think we will then understand that in early breast cancer, hormone positive, HER2 negative, biology becomes the king. Not everyone will require chemotherapy. The low risk will be definitely away from chemo. Cutoff of 60 looks very good. I told you the difference of discordances between oncotype DX and the high PAM. That is there, people remember. So low oncotype can have high PAM. The low PAMs will have low oncotype, but the low oncotype can have high PAM. The cohort has expanded for me. From 50 to it has come to 40 years. From the node from 0 to 3 nodes, now it has come to 9 nodes. But I think all of us, like Ankur and Ankit told, they won't change practice. Most of the oncologists will not change practice, especially in the young and the elderly. But if there's a 75 years old female, a little skeptical, little comorbidities, 8 nodes positive, one will bank upon this data set to give them chalo pan 50 kar lo. R is 40, you will not receive chemo. I think that is where the practice will be at this point. Lidera, as Ankur told, wait for further mature data. But this is the future. I believe the third plus CDK4/6, if the data is mature someday, once the data comes in, and if it is better than CDK4/6 plus AI, this is going to be a practice changing trial. I'll stop here. Thank you, Ankit. Thank you, Ankur. And I hope we have added something to the knowledge of everyone who was listening to us.
Thank you,
Thank you,
sir.
sir. That was wonderful. Thanks a lot for getting it. Um, Manya, can we call our next speaker? Thank you, Ankur. Thanks a lot
Yes,
for
sir.
a wonderful panel discussion.
So, thank you, sir. Thank you so much, Dr. TP Sao, for a wonderful panel. And we move forward for the sponsored session by AstraZeneca. And for this, I would like to invite Dr. Jitendra Kumar Pahelejani, Consultant Medical Oncology at HCG Cancer Center, Jaipur, for the talk on DB09 first line HER2 positive MBC and HER2 plus pertuzumab. Over to you, sir.
Thank you
जितेंद्र
so
अगर
much.
जानता ना जितेंद्र है मैं ऑलरेडी उसको बुला लेता आज पैनल में तो
सर नमस्ते, कभी भी सर.
जितेंद्र चलो कैरी ऑन प्लीज
Okay. So, good evening to all. Thanks, Dr. Ankit, for inviting me. So, can somebody share the slides? So, this is DB09. So, after hormone positive breast cancer discussed, probably the next wish, which we all like to discuss, is HER2 positive breast cancer. So, this is the DB09 data in a metastatic space. So, these slides are provided by AstraZeneca. So, obviously the sponsor session. So redefining outcomes in first line HER2 positive metastatic breast cancer with TDXD plus pertuzumab. Next slide. So coming to the points, what were the unmet need in management of HER2 positive metastatic breast cancer? Current treatment landscape for first line HER2 metastatic breast cancer. DB09 redefining outcomes. DB09 data, TDXD and pertuzumab dosing and TDXD related AE management and the summary. So we have 15 minutes for this and we will discuss. So before next slide. So as we all know that HER2 used to be a poor prognostic factor, but now we are next slide please. Now we are targeting HER2 in various settings by various ways like TKIs, ADCC, the conventional trastuzumab. So that has led us from a long way, but still we have patients which have primary HER2 resistance and secondary HER2 resistance. These patients progress over time. Next slide. Next slide. So this is the treatment landscape that We came to know about HER2 aggressive phenotype by 1995. 1998, we had trastuzumab. For over 15 years, it was the regimen of choice. Then we had pertuzumab. And after 2020, we had a lot of molecules like TDM1, lapatinib, TDXD, tucatinib, neratinib. So all these agents are used in HER2 space. Next slide. So one third of HER2 positive metastatic breast cancer were not able to receive second line therapy, underscoring the importance of early intervention to maximize survival outcomes. So these 33% patients are usually primary trastuzumab resistant, we can say. So out of these 60%, around 74% patients will also not be able to receive the third line treatment. Patients with de novo HER2 positive MBC experience superior survival outcome compared with the recurrent disease because we all know that if the patient has a disease occurrence or recurrence within 1 year of the treatment, or to be frank, within 6 months of the treatment of anti-HER2 therapy, their lifespan are usually lesser and they have poor prognosis. So if a patient is running upfront metastatic disease, they are more likely to have a longer survival outcome, less likely to have baseline CNS nodes, more likely to have a baseline bone or liver disease, and less likely to have a hormone positive disease. So this is the data. If patient is de novo, the median PFS is 17.7 months versus 11.9 months. Next slide. So de novo HER2 positive disease and disease recognition improve survival and lower CNS metastatic burden. So median OS, if you see the de novo disease in HER2 positive metastatic disease, is not reached uh, in de novo versus it is 44.5 months under various studies. Around 10% patient will have disease, CNS metastatic disease if patient is HER2 positive. It is 4.3 when the patient is de novo, and around 13.5% is patient is recurrent. Next slide. So hormone status is also important while treating this patient. HR negative tumors typically demonstrate a worse prognosis compared with the HR positive tumors. And if patient is HR negative, we know that once the patient lose HER2 positive status or they are stop responding to HER2 positive therapy, then treating them is very difficult. Next slide. So visceral and brain metastases are prevalent in patients with HER2 positive MBC. Means we say that around 50% patients will have brain mets in a metastatic breast cancer if they are HER2 positive, and these are related to the reduced survival. So visceral metastasis in HER2 positive breast cancer are because of non-luminal diseases, which involve soft internal organs like liver, lung, and other organs like ovary. 47% of patients in first population presentation of HER2 positive will have visceral metastasis. Most common site will be liver, and liver metastasis is also a risk factor for development of brain metastasis. Brain mets are around 25 to 50% of the population. Usually, brain mets is associated with poor survival. It's considered a late event, occurring around 2 to 3 years following initial metastatic diagnosis. In Cleopatra, around 48% of the patients developed brain mets at the first site of progression following transplant. THP. Next slide. So there are several key unmet needs. Lack of first-line advances means we are using Cleopatra since 2012. Although the data we face, 31% patients were only able to survive. Sorry, 37% patients were only able to survive for 8 years. So we have a lot of work to do here. Recurrent disease is common, means the patient who have treated with HER2 positive intent, still the patient had poor outcome, and they usually have to recurrence are higher than other hormone positive subtypes. Visceral and brain mets are more common in HER2 positive space. Despite advancement, prevention and treatment option, HER2 positive metastatic brain cancer breast cancer with brain mets have been historically limited. Hormone-associated negative patients demonstrated a poor prognosis. Next slide. So this is regarding the current landscape. Next slide. So for now, THP has been the established first-line standard of care since 2012. No first-line regimen was introduced for over a decade. 5-year survival rates below 50%. To be precise, 37% at 8 years. Patients continue to face the risk of disease progression and CNS metastasis. So DB09 makes a marked advancement in the first-line HER2 positive metastatic breast disease setting, addressing a long-standing unmet need. Next slide. So NCCN also incorporated into its version 4 of 2026 as other recommended regimen. And TDXD plus pertuzumab is now considered as a category 2A regimen. Other recommended regimen for are PTSSP, basically trastuzumab, pertuzumab, taxol in any form. Next slide. So this is what the ESMO says. ESMO also has added pertuzumab and TDXD in their guidelines, and it has a category 1A recommendation and MCDS score of 2. Next slide. So this is the Cleopatra, which established the THP as a adding of pertuzumab to taxol and trastuzumab versus 40.8 months. So around 18 month gap Cleopatra. Thank you, sir. Connected हो गया मैं?
Sir, you are not audible.
Hello?
Dr. Jitendra,
So this
yes,
is
you're audible now. Yes.
yeah. So now this is the patina. Actually, the patient is hormone positive and patient responding to the Cleopatra regimen. The point of adding palbociclib to hormone therapy and trastuzumab pertuzumab will lead to hazard median PFS advantage of 44 versus 29.1 months with hazard ratio of 0.75. So patina is for hormone positive and HER2 positive patients. So tumor response was also increased by adding palbociclib by 8%. Next slide. So this is the PFS data, 24.9 months versus 16.3 months after randomization. Next slide. So coming to the Destiny 09 study. So here
So
the
request you to conclude your presentation in 1 minute.
now yeah
Thank you.
the objective was patients with brain mets were excluded from the Cleopatra study. DB09 provided data to support that use of PDXD in first line to improve outcomes in patients with HER2 positive MBC. So DB09 will stratify patient by prior treatment status, HR status, PIK3CA mutation. These subset analysis will provide valuable data regarding TDXD use in patients with unmet needs in HER2 positive MBC. Next slide. So here we can see that pertuzumab versus DDXT, they work on different domain of R2 receptor, and that's why there was a synergistic effect on the tumor cells. Next slide. So this is the trial design. Patients were randomized to TDXT plus pertuzumab, THP taxane for more than 6 cycles followed by HP, and TDXD for placebo. So this TB09 data is for TDXD plus pertuzumab versus THP. Next slide. Next slide. So this data get off on 26 February 2025, and the on 38 126 event was occurred, 16% of total numbers. Next slide. So here we can see different definitive separation of term. Median PFS of 40.7 months versus 26.9 months in the THP arm versus TDHG plus percentage arm. Next slide. With a good PFS hazard of 0.56. Next slide. So here we can see that there is separation started from 6 months itself with around 6% difference, followed by 13% difference, and around 20% difference in PFS. Next slide. So this is regarding the PFS outcome across various subgroup, and we can see that HR was favoring all the subgroup, even the brain mets, pituitary mutation, hormone receptor status, and previous exposure to particulate. Next slide. So this is regarding the subgroup of previous exposure to endocrine therapy, exposure to anthracycline, age, geographic region, proposed status. So all the subgroup analysis favored the PDXD pertuzumab. Next slide. So this is regarding the PFS2 versus THP. This was assessed by investigator, and here we can also see that patient who were received TDHD as the frontline regimen, whatever second line they received, the PFS2 was significant in the TDHD alone, TDHD particular. Next slide.
So request you to kindly conclude.
So next slide, here we can see that despite adding TDHD pertuzumab, all the patients were able to tolerate the regimen better, and only shortfall is patient has to take the PDHD for the longer run. So basically the evaluation for ILD is important, and we have to keep that in check for a longer duration. Thank you for patient listening.
Thank you, Dr. Jitendra. Just one point of discussion. Um, uh, uh, how frequently have you seen ILD in patients whom you've given TDXD? Data says that we see around 20% of the patients. Do we see it so frequently in our clinical practice?
Around 5 to 10%.
Yeah, I think Dr. Ajay is also online. Dr. Ajay sir, we would like to ask you the same questions. How frequently do you see ILD in your clinical practice when you use TDXD?
Oh, not so frequently.
Yeah, I think it's more of, I don't know, very surprisingly the side effect that the clinical trials have said, we don't see that so often, right? It's very surprising because ILD, yes, we do need to monitor patients with HRCT thorax every 6 weeks, but I think it's a good drug. Patients tolerate it really well. Apart from some fatigue, I don't think ILD is we need to worry about. That's what I feel.
And
And
response rate and the depth of response is very good in
it's
this.
amazing.
Very good.
I'm very interested if there comes up a data where we can use a TDXD as a single agent and you don't have to combine it with pertuzumab. I think that also should produce a fantastic data.
Yes.
Yes, I think DV09 is something that is practice changing. Okay. Thank you, Dr. Jitendra, for a wonderful discussion. We'll move on to our next speaker. We have Dr. Ajay Yadav. He is a senior medical oncologist at Mahatma Gandhi Hospital, Jaipur. He'll talk about the role of BCMA bispecifics in relapsed refractory multiple myeloma. Dr. Ajay, over to you.
Thank you, Dr. Ankit. So next 15 minutes, we will discuss about role of BCMA in multiple myeloma. And this is a Pfizer sponsored session. Next slide, please. My slides.
So yes, sir, we'll share. Team kindly share.
So in last couple of years, there has been significant improvement in outcome of these patients. And multiple myeloma has become a chronic disease. After subsequent lines of treatment, when disease progresses, we need more and more drugs which can be given to patient, which can be tolerated by patient and which have efficacy. So BCMA is a class of drug which is targeted therapy which has shown efficacy in different clinical trials, phase 1, phase 2. Next slide. So one is elrantamab, and this is a BCMA directed bispecific immunotherapy which has been found to be effective in relapse refractory multiple myeloma. Next. So this is indicated as monotherapy for patients who have received multiple lines of treatment, including daratumumab, including bortezomib, and pomalidomide and carfilzomib. Next. So this is the agenda for today's meeting. We will see the unmet needs for patients with relapse refractory multiple myeloma who are triple class exposed. What is the present longer term follow-up data demonstrating the efficacy and safety of Elduxio, that is elrantamab, in range of patients. And we will discuss the key consideration for Elduxio dosing and administration. Next slide. So after failure of 3 or 4 lines, multiple myeloma patients have poor prognosis, and the median PFS remains very low, less than 6 months, and overall survival is usually less than 12 months. And poor outcome in these patients who have TCE demonstrate a need for improvement in treatment for these patients who have heavily treated. Next. So elrantamab is a BCMA-directed bispecific antibody, as name suggests. On one side, it binds to the CD3 cells on T cells, and on another side, it binds to the BCMA, which are present in plasma cells. So this is the mechanism of action. This binding leads to activation of T cell and cytolysis of BCMA expressing cells, and activated T cells causes pro-inflammatory cytokine release, which results in lysis of these tumor cells. Next. So efficacy and safety of elrantamab was assessed in Magnetis MM3 trial, which was a phase 2 trial, which included the patients of relapse refractory multiple myeloma. Next. This is the trial design. They have included patients who have heavily pretreated patients who are fit for treatment, and they excluded the patients with prior treatment with any BCMA directed therapy. So patients were randomized to receive BCMA directed therapy. These all patients were BCMA therapy naive patients, and the primary endpoint of this trial was ORR. Efficacy was based on ORR and DOR in patients who received 4 or more prior lines of therapy. Next slide. And here you can see that 70% patients responded to the treatment after failure of multiple lines. And the duration of response was maintained. Around 70% patients responded to this treatment. The MRD of 46 patients who achieved CR, 31 were evaluable for MRD, and in these patients, 90% patients achieved MRD negativity. So there was deep response. Next slide. Median PFS, it was 17.2 months, and here we can see that these curves started to separate right from the beginning. With a good hazard ratio, median PFS was 17.2 months, and overall survival, it was 24.6 months. Remember that these are the patients who have received multiple lines of treatment. Some of these patients have received more than 8 or 9 lines of treatment. Next slide. Now about the durability of response. After longer follow-up, the median duration of response was not reached at 33.9 months. And the probability of maintaining a response at 30 months was 80% versus 60% in control arm. Next slide. So response time in Magnetis MM3, median time to response was 1.2 month, and Alduxio delivered rapid response for these patients, and this analysis is not powered to detect the significance and are presented for descriptive purpose only. Small patient number and lack of multiplicity adjustment can be limitation of this analysis, and these data should be interpreted with caution. Next slide. MRD negativity rate among these patients who achieved CR. So there was high rate of MRD negativity in these patients, who shows the depth of response. Among 21 patients who were evaluable for MRD, 90.5% patients achieved MRD negativity. Next slide. So now we come to the toxicity, adverse effects. Next slide. These are the common toxicities which were demonstrated: anemia, neutropenia, thrombocytopenia, lymphopenia. These were the common adverse effects. Non-hematological toxicities like CRS, diarrhea, fatigue, anorexia, pyrexia, these were common toxicities. Treatment emerging adverse effects were reported in 100% of patients, with 70% experiencing grade 3 or 4 toxicities. 55 patients died on study, and the majority of these patients have progression of disease, and 4 deaths were deemed to be treatment related by investigator and caused by adenoviral hepatitis, adenovirus infection, pneumonia, and renal failure. Next slide. Neutropenia and hypogammaglobulinemia is common toxicity with this molecule. And as neutropenia and hypogammaglobulinemia are associated with increased risk of infection, they were both evaluated in this trial. So there was 45% incidence of these toxicities. Next slide. So treatment emerged adverse effect leading to dose modification. 28.5% patients needed dose modification, and most common adverse effects that leads to dose reduction were hematological toxicities, neutropenia in 15% cases. And dose interruption, it was required in 77% cases, and most common adverse effect that leads to interruption were infection in around half of the patients, and most commonly COVID-19 related in 25% cases, and there were some other infections also. Hematological toxicities, most commonly neutropenia in 35% cases, was responsible for interruption of dose. Next. So, as observed in most BCMA targeted T cell directed therapies, infection were common in Magnetis MM3. Overall infection were 71%, and grade 1 or grade 2, they were 51%. So half of these were grade 1 and grade 2. 42% were grade 3 and 4. And the most common infection were respiratory, coinciding with the COVID-19, as the COVID was there at the time the trial was ongoing. And this is the list of other infections, including pneumonia, upper respiratory tract infection, sinusitis, and urinary tract infection. Next slide. So how this drug is administered? This is administered once weekly, then once every 2 weeks after 25 in responding patients. And pre-treatment medications, when we require 1 hour prior to the first 3 doses, both step up and doses, that the first treatment doses, these patients should receive acetaminophen 650 milligram orally. We need antihistaminics, dexamethasone 20 mg before administration of drug. Due to risk of CRS, patient should be hospitalized for 48 hours after administration of first step-up dose and 24 hours after administration of second step-up dose. 98% of CRS events occurred within the first 3 doses. So it should be monitored closely for first 3 doses. And continue the treatment with L-Duxio until there is disease progression or intolerable toxicities. Next slide. So prevention and mitigation of these infections and other adverse effects like neutropenia and hypogammaglobulinemia can be done with these strategies. Infection can be treated. Infection can be prevented with prior immunization. Prophylactic antimicrobial, antiviral should be administered. Updated vaccinations are recommended before starting the vaccine. Antiviral, antibacterial, and antifungal prophylactic drugs should be used. So patients should be monitored for sign of infection during treatment, particularly for initial 1, 2, 3 cycles. And patient should be referred to the local institution. We should follow the local institutional guidelines and IMWG guidelines for additional details regarding prophylaxis for these patients who are on elrantamab. Next slide. So prophylactic antimicrobial agents were administered to patient in Magnetis MM3, antiviral in 87% cases, antifungal in 11% cases, antibacterial in 6%, and 50% patients received anti-PJP. Next slide. So therapy can be delayed to manage the treatment-related toxicities if they are grade 3 or 4, particularly when counts are low, febrile neutropenia is there, platelet counts are low, and infection that require hospitalization in IPD or in ICU. So dose delays are recommended for grade 1 and 2 and first occurrence of grade 3 events, and permanent discontinuation is recommended in case of grade 3 or 4 toxicity. Next slide. So recommendations for restarting after dose delay. If patient has improved, if the toxicity was grade 1 and 2, and it subsides, then we can restart the drug. If patient have grade 3 or 4 toxicity and still having symptoms, then we should discontinue the drug. Permanent pre-treatment should be administered prior to every dose. Next slide. So timing of CRS and ICANS is predictable with elrantamab, with risk mitigated by step-up dosing. So on day 1, 12 milligram, on day 4, 32 milligram. 2 or more days should be maintained between step-up dose. And the majority of CRS and ICANS events were grade 1 or 2, occurred within the first 2 doses, and they were of short duration. From week 2 to 24, the first full dose should be given at 76 milligram, and subsequent weekly doses should be given at 76. and switch to Q2 weekly dosing after 6 months for patients who have at least PR. And after week 25 plus, Q2 weekly dosing of 76 milligrams should be continued till the response or there is intolerable toxicities. Incidence of grade 3 and 4 adverse effect decreased after patient in the BCMA directed therapy naive cohort switched to Q2 weekly dosing. Next slide. So CRS and ICANS events were low grade and they were usually manageable. CRS incidence was around 57% and majority of these events occurred within first 3 doses. Median duration was 2 days. ICANS, the incidence was 4.9% and the median onset was 2.5 days. Median duration was again 2 days. CRS was associated symptoms included fever, hypotension, and hypoxia, and the supportive care included tocilizumab and siltuximab and corticosteroids. For ICANS, most frequent symptoms were depressed level of consciousness and grade 1 or 2 IC score. Supportive care included corticosteroid, tocilizumab, siltuximab, and anakinra. So early intervention may help to prevent the additional toxicity and shorten the hospital stay for CRS and may help to prevent progression of ICANS. Supportive care can help manage and mitigate the severity of CRS and ICANS. Interleukin 6 are inhibitors and corticosteroids are the common supportive care therapies required to prevent CRS and ICANS. To reduce the risk of CRS and ICANS during the first few doses when it is most frequently occurs, step-up dosing and pre-medication helps to mitigate the risk and severity of CRS. Next slide. So this is the incidence, management and mitigation strategies for infection, neutropenia and hypogammaglobulinemia. The incidence of infection, it was 93.5% for those who were rechallenged and had a successful restart. After 32 months of follow-up, infections occurred in 70% cases and grade 3 or 4 was 40%. And neutropenia and hypogammaglobulinemia can increase the rate of infection. Around 50%.
So kindly conclude the session.
Yeah, few slides are left. So next slide. So elrantamab demonstrated durable response and survival after 32 months of follow-up. There was deep response rate was 61%. It was durable, median PFS was 17.2 months and the toxicities were manageable. Adverse events reported were consistent with non-safety profile. Next slide.
Sir, request you to conclude your presentation in 1 minute.
elrantamab is available as an off-the-shelf formulation for subcutaneous use. Next slide. With this, I complete my presentation. I'm very thankful to Dr. Ankit Agarwal for this academic activity and thank you Pfizer for sponsoring this. Thank you, Ankit.
Thank you, Ajay sir. Thanks a lot. I think we need to be more confident about using BCMA bispecifics for relapsed refractory multiple myeloma, considering ICANS infections. I think more and more experience with BCMA bispecifics will give us more confidence in using these drugs. Definitely, good drugs at such a high risk profile patients, and I think time with more confidence, with more experience, will be more confident in using these drugs.
Yes, and particularly for patients who are diagnosed at earlier age, who suppose a patient is diagnosed at age of 40 and post-transplant, post-multiple lines of treatment, when therapy fails, these drugs are particularly helpful.
Yeah. I think absolutely agree. Okay, thank you, Ajay sir. Can we move on to our next speaker?
Yes, sir. So for the next talk, I would like to invite Dr. Abhishek Sharma. consultant medical oncologist at Goel Hospital and SKG Cancer Center, Jodhpur, for the talk on immunotherapy in advanced ESCC. Over to you, sir.
Yeah, so my screen is visible now.
Yes, sir.
Yes.
Abhishek, you have a
Uh,
new look.
yeah. Thank you, Ankit boss, for this opportunity, for a wonderful academic meet for all of us. So I'm just here about the immunotherapy in especially advanced stage esophageal squamous cell carcinoma. This sensor is sponsored by the DRL. So we are going to discuss about the mainly immunotherapy drugs right now available in the esophageal carcinomas. As we all know, pembrolizumab, nivolumab, toripalimab, and tislelizumab. These are the four most commonly used immunotherapy drugs. So right now we are going to discuss all about that. So definitely esophageal cancer, a global health problem. We all of know 11th most cancer worldwide, 7th most cancer common cancer as a cause of death. Global incidence quite high as well as mortality rate is high in the especially squamous cell carcinoma part. And definitely this is falling in the incidence falling in many developed countries, especially squamous cell carcinoma. But yes, adenocarcinoma incidence is increasing in developing countries also. So when you look at the Indian population, this is the fifth most common and as well as fifth leading cause of cancer death in India. Incidence is quite high, death is quite high, 5-year prevalence, you can clearly see this is quite high in numbers. So there is a some unmet need in the advanced esophageal carcinoma patients, likely highly aggressive disease with poor survival, with a significant disease burden and mortality in India. Almost 50% or less patient may not survive or have a chance to receive second line therapy. Limitation of the PD-L1 as a biomarker, large PD-L1 negative population, and definitely current guideline only restrict to the approved PD-L1 positive population and the robust evidence of using taxanes and platin as a backbone. Most of trials have a platins with a 5FU data and as well as some real world evidence also, especially Indian evidence. This is the unmet need in advanced small esophageal squamous cell carcinoma. So this is the first line is advanced studies. You can clearly see I am talking about the keynote. You can clearly see median OS in the population, all population. Yes, this is a benefit in the survival in form of overall as well as progression free, but the benefit robust in the when score more than 10. Clearly see hazard ratio 0.57 for both PFS and OS, and significant benefit and as well as suppression of the curve. So approved for the most pronounced benefit in the squamous cell carcinoma when PD-L1 CPS more than 10. And when I talk about the checkmate 648, nivolumab definitely benefit in the OS and PFS for all, but profound in only TPS more than one. You can clearly see 9 versus 15 month, 4 versus 7 month, well separated curve, definitely. So this is indicated when TPS score more than one. But what about the population, those who have a PDL negative? Because the large number of PDL1 negative, around 30-40% cases, 40% cases are PDL1 negative, especially in the squamous cell carcinoma. So definitely this is an unmet need in the patient, those who have a negative PDL1. So Jupiter study is very well designed phase third trial. They include patient up to 75-year-old age, recurrent, advanced, and metastatic, treatment naive or relapse more than 6 months and 12 months if paclitaxel or taxane and platinum is used, especially for non-metastatic conditions. No prior use of immunotherapy, ECOG is 0, 1, and this is 1.1 they uses. They randomize patient according to toripalimab 240 milligram 3 weekly with the paclitaxel and cisplatin up to 6 cycle followed by the toripalimab maintenance every 3 week till progression or 2 year. And they compared with the chemotherapy only. Primary endpoint is a co PFS as well as OS, and secondary endpoint is a well matched with the like other trial only, overall survival, PFS, and all. When you look at the baseline characteristic, well, we male match, age, male, ES, PS, disease status, pedal expression, very well matched in the both group. You can clearly see CPS score. They are well matched in the both group. And when you look at efficacy data, especially overall survival, hazard ratio is 0.58. That is quite good. P value is highly significant. 42% reduction in the risk of death. And when you look at the 2 year data, that is not reached in this arm versus 17 month. And when you look at when 1 year OS data, 40 versus 66 month. So this is clearly showing a good benefit in the patients. And when I move to the subgroup analysis of the overall survival, this forest plot favored toripalimab is better in the all subgroup, more or less one only. Otherwise, beneficial in the all subgroup of toripalimab. When you look at the PFS data, stratified hazard ratio is 0.58, 42% reduction in the progression or death, and 1 year PFS 6 versus 27 month to 6 versus 27 percentage, and median PFS 5.5 versus 5.7 month. So you can say this is the clearly benefit in this PFS data also. And when you look at the subgroup analysis, toripalimab is doing better in the all subgroup, irrespective of PD-L1 less or more. Definitely, maximum benefits when seen in the more than 10, but yes, there is a quite significant benefit also seen in the PD-L1 negative patients also. And when you look at the tumor response rate, around 11% CR rate, around 60% PR rates, around 20% stable disease. When you look at a PD is around 7 versus 13, 14 month in the chemotherapy arm. When you look at the overall response rate, that is quite good, 70 versus 50. And when you look at a disease control rate, around 80 to 90 versus 80, and duration of response around 6 months versus 4 months. So the data is quite convincing with in form of PFS as well as OS as well as response rate. And when a safety analysis, this is more or less similar. We all are able to manage the safety profile of immunotherapy drugs right now. So yeah, this is quite acceptable. Definitely different side effect profile. Otherwise, chemotherapy profile both are same and more or less similar side effect is in this arm. This is a post hoc analysis of this study, especially PDL1 TPS more than one and less than one OS analysis. You can clearly see separation of the curve. You can clearly see the hazard ratio and as well as p-value. Both are significant in the both group. And yes, PDL1 1 year OS rate, this is around 66.4 versus 47.2. So yes, this is quite significant in this population. Definitely, this is a population where we need something to add as a immunotherapy. So toripalimab is the answer, especially in the PDL1 less than 1% patients. So this is about the PFS in this part also. PDL1 more than one and PDL1 less than one, and the PFS rate 28% versus 7% in this when PDL1 score less than one patient. So toripalimab doing better in all subgroup, especially on the basis of the PDL1 because less than one, more than 10. This drug is doing better in form of progression-free survival as well as overall survival and as well as response rate also. So tumor response with the toripalimab versus placebo, when you see for the PD-L1 negative patient, response rate with the tori group is around 74 versus chemo group around 40%. So you can say 20% improvement in the overall response rate in the PD-L1 negative group. And when you look at the CR rate and as well as PR rate and stable disease, that is quite good in this. And the PD ratio more or less similar in the both group. So you can PD is more or less little bit high in the placebo part, but yes, response rate is quite good with the Jupiter Geo6. And so this is a meta-analysis. They complete the 17 trial that showed involvement around 9,000 patients, and the primary outcomes were the OS and as well as PFS. That is published in the I think Lancet by the some Chinese physicians. And the for clear statistical analysis, chemotherapy were divided into two category: 5 based or 5 free. And definitely you can clearly see the study included a 17 trial as well as some exclusion and inclusion also. And this is the result of this meta-analysis. Toripalimab plus 5-FU-free chemotherapy demonstrate best OS advantage among the all IOs because there is no head-to-head comparison. We cannot comment which is better than which one, but definitely on this meta-analysis and cross-trial comparison, toripalimab doing better compared to all other IO in form of this meta-analysis hazard ratio as well as response rate as well as PFS and OS. So and definitely PDL1 low, definitely toripalimab is doing better, but it's in higher cases we have to discuss with the all pros and cons. So this is the EMA granted marketing authorization for the esophageal carcinoma. So in combination with cisplatin and paclitaxel, indicated as a first line treatment for the unresectable advanced recurrent metastatic esophagus squamous carcinoma. So the ICEB approval, toripalimab in combination with paclitaxel first line treatment for the patients, irrespective of PD-L1, tislelizumab when TAP score more than 5%, pembrolizumab patient for the pedal expression more than 10% and Nivo more than 1%. So this is the approval. Tori approved irrespectively. Otherwise, all are required the pedal one expression. This is some real world evidence of Indian data. This is basically Indian respective data by Dr. Pinati sir and Chandrakant sir, and as well as Ankur Bell sir also. So they done this analysis of toripalimab, especially in the esophageal squamous cell carcinoma. So this is a retrospective study, definitely population more or less similar squamous carcinoma, multi-center, 5 Indian territory care center also. And study outcome is overall response rate, disease control, real world PFS, and treatment related adverse event. So characteristic is quite good because on the basis of what the visceral metastasis or not. So around 31 patients they had in this cohort. Their median is around 60%, 74% is the high disease burden with visceral mets, 38% PD less than 1%, and 40% receive first line first line therapy. So this is the real world data. And when you look at this overall response rate, around 60% and 70%, you can clearly see. And when PD expression more than one, overall response rate 52%, and less than one is around 77%. And when I look at the PFS data, this is around 7.7 versus, and PD less than percent is around 6 months. 6 months. So this is quite good with this result on a PDL1 less than 1% with the response rate 77. I think this is a quite high impressive data with this toripalimab. So, but I don't know what the reason behind this. So much a good response rate in the PDL1 less than 1%. And when you look at a PFS, that is quite good. So this is the quite a good evidence for us. And definitely side effect, both are similar, all are manageable, mostly are hematological on the basis of chemotherapy arm, but immunological, this is no as such. So we did need to treatment discontinuation and delaying. So yes, I can say this is the most safest data we have. And so conclusion for that, toripalimab demonstrated clinically meaningful activity in real world evidence of squamous cell carcinoma with overall response at 60%. Duration of response is quite good with the median PFS around 6 to 7 months. Efficacy is demonstrated well tolerated, no side effect, no discontinuation of drug. So these findings provide first real-world evidence of toripalimab in the squamous cell carcinoma from a non-Chinese population, that filling a critical evidence gap. So this study matter by for the first time in the multi-center Indian real-world setting that toripalimab delivered clinically meaningful response with excellent safety profile, even in absence of PD-L1 biomarker selection, providing external real-world experience to guide oncology to treating advanced esophageal squamous cell carcinoma in India. And what the clinical implication? So that type of evidence been found as a first line PD-L1 negative as a real world data in squamous cell carcinoma. For a global oncology, add on non-Chinese real world evidence to evidence base, improving generality of exciting randomized control trial data for global clinical guidelines. And definitely, this is the future research and strategy to evaluate are warranted. So my summary for the Juniper Jupiter 06, regardless of PD-L1 CPS level, Toric is doing good with significant OS and PFS. And the chemotherapy backbone that is quite acceptable, especially platin and taxane that are we are using in our daily clinical practice. And sometimes this is difficult to give a patient 5 days chemotherapy. The post-hoc analysis is clearly showed benefit in the PD-L1 negative patient, and toripalimab is the only approved by EMA irrespective of PD-L1. So I am concluding all of that. Thank you so much.
Thank you, sir. Thank you so much for the wonderful talk. So, can we move forward, Dr. Ankit Agarwal?
Yes, yes.
Dr.
I think. Thank you, Abhishek. Thanks a lot as usual.
Thank you, boss.
Wonderful talk. Yeah,
Thank you.
We'll move on to our next discussion. Can we invite our next speaker, please?
Sure, sir. Sure. So, next, I would like to invite Dr. Bharat E. Vaswani, Clinical Director, Medical Oncology and Hematology, Yashoda Hospital, Hyderabad, for the talk on From the Lens of ESCO 2026. Over to you, sir.
Good evening, everyone. Am I visible and am I audible? Both important.
Sure, very much, sir. Very much.
Yes, audible. Please go ahead.
And are my 1 minute? Yeah, my slides are visible, right?
Yes, sir. Yes, sir.
Right. So let me thank Ankit, let me thank Tarun for a kind invitation. In the next 15 to 17 minutes, I'll be discussing or telling you what was new in this ESCO annual conference 2026 in terms of lung cancer. I have tried to take out my own slide. I was given some slide, but I thought within the 15 minutes, let me tell you what was good and what was which is important for our practice. So I'll be telling you in short about the four studies: Liberto 432, Harmony, Crown Update 7-year, probably more clinically important and probably the most potent drug in exon 20 insertion. Suddenly, this field has become crowded with lot of new drugs recently. So, what is this best drug all about? And a word or two about the final update of tarlatamab and one more study which is in atypical EGFR mutation, Chrysalis 2. Please remember, if you remember, if anybody has gone through ESCO very clearly, there were 5 plenary presentations. And out of the 5, 2 were in lung cancer. So lung cancer carried the biggest plenary, 2. Other was a abemaciclib, a palutamide, and a wonder drug, pan-RAS mutated daraxonrasib. But 2 were Liberto 432 and Harmony 6. These were both plenary, plus there was the 4. So let me start with the first of the 2 plenary presentation what was done. Event-free survival for adjuvant selpercatinib. We know selpercatinib has been with pralsetinib are the best drugs in RET fusion in metastatic. But this is the time where the third drug, we have Adura study and we have Elena study. Now this is the third study in an adjuvant setting for RET fusion positive phase 3 data, Liberto 432. So this is all we know. Two drugs which we test in early CA lung, which is EFN and ALK, and now with this study, we will be testing this selpercatinib or a RET fusion. I will like you to just concentrate on hazard ratio. 0.17 for EGFR and ALK for Elena, it is 0.24. So whenever we use a drug, in fact, why I am trying to tell you is when they started the trial, they kept a hazard ratio of 0.50. But looking at these two impressive data, they reduced it to 0.24. And whether this hazard ratio was really satisfied, we will see. So upfront early CA lung 1B, 2, 3A. Please remember the endpoint, the primary endpoint did not include 1B, but it was 2 and 3A. Selpercatinib for 3 years. And the primary endpoint was event-free survival in stage 2 to 3A. Overall, they took 1B also, but they did not take it because the numbers were long. And they really wanted to look into the impact factor which was there. So when you look into it, never smokers was 68.5 and 90% of the patient received first chemotherapy followed by 3 years of selpercatinib. Now, how do you diagnose lung cancer early in a never smoker where there is no screening available was a difficult thing, and that was debated post presentation of this talk. Now, when you look into the primary endpoint, now these are impressive numbers. At the end of 2 years, if you see the event-free survival, 91.5 versus 61.1. So nearly 30% absolute improvement in event-free survival. So probably these are bigger and better number. And when you look into the hazard ratio, 0.17. So agreed. This again looks so impressive as like the 2 previous studies in adjuvant setting with an absolute improvement of 30% in terms of event-free survival, a highly statistically significant with a hazard ratio of less than 0.001. Now, when you combine stage 1 also overall, again, this quantum of benefit continues to be the same with the hazard ratio of 0.16. So 0.16, 0.17. Now, when you look into forest plot, all the subgroup benefited, whether it was old, young, male, female, smoker, never smoker, stage 2, stage 3A, prior chemotherapy, yes or no. In fact, no, it was, if you say it started immunity, but then it was few numbers, n number was only 9, so no point in discussing all about it. Now, when you talk about a drug in adjuvant setting, you have to most importantly see about toxicity, because anyway, the cancer may come or not, and that is where you have to be careful pretty. Grade 3 treatment emergent adverse event was 66%. Dose modification was in 88%. So you have to be careful using. But what they suggested is majority of the patient had transaminitis. That caused, because being in a trial, you have to be strict. So they had transaminitis. And the discontinuous study was 17.3. So this is something where quite high. Nearly 1 in 5 had to discontinue, mostly due to transaminitis. But what they said is it is manageable with dose discontinuation. 80% there was modification, but 17% discontinuation. The commonest side effect which we have to remember is SGOT, SGPT elevation, followed by diarrhea, dry mouth, cough, hypertension, constipation, uremia. Try to look into grade 3 adverse event on the right side. Except for transaminitis and some of the hypertension, there was less of a grade 3 side effect. But as per as protocol, majority who discontinued was due to transaminitis. So what did this study say? Why was it was probably what we say the plenary? We have a new standard of care for early stage RET fusion positive NSCLC, first and the only randomized 3 trials, which showed that yes, this drug also given in early rare subtype improves your event-free survival. What it suggested, rather than doing this EGFR, we should do a NGS, what we do. So probably I do everything. I don't do singly. I do NGS for all my lung cancer patients, irrespective of adeno and squamous. That is a dictum that we follow. And if you have to summarize, I have to tell now there are 3 driver mutations where we have to use a drug in the early CA breast, EGFR, Adura, Alkalina, and now RET liver 432. What is make it selpercatinib joins OC and elect as a proven targeted therapy in adjuvant setting? Precision oncology now defines management in early stage NSCLC. But yes, there are some questions to be answered. 3 years, what after 3 years? If 3 years the right treatment, think of your Adura. That quantum of benefit, the maximum recurrences occurred only after 3 years. So same, maybe this could be there. What about the CNS? We don't have a proper data. OS benefit, early days. And the most important thing practically, how do you identify early stage in no smoker where there is no guidelines, what we say screening. The guidelines is for smoker 20 years, less than 15 years of smoking, and majority of the patients were non-smokers in this study. So yes, one study which probably will be incorporated in NCCN. It is a matter of time now. The second study, which was again a plenary presentation, was Harmony 6. This drug we are hearing for the last 1 year. Last year also there was Harmony against pembrolizumab. Then there was a ESMO PFS presentation of this Harmony 6. What is different of this Harmony 6 from other is it is metastatic squamous cell carcinoma only, same subset. So that subset where even pembrolizumab don't work or immuno also works to a limited extent as compared to adenocarcinoma. What is ivonescimab is a bispecific PD-1 plus VEGF. So probably in a layman's language, you can combine BEV also. And we know we don't give BEV in a squamous cell carcinoma. So what has been suggested is VEGF, PD-L1, probably they have a complementary effects because dual antibody targets the antibody in a tumor microelement, increases affinity of PD-1 and probably potentiate the anti-tumor response. We already have 2 approvals in China. This is what we had Harmony A study and Harmony 7 study where it has already been approved post EGFR first line failure and as a monotherapy in PD-L1 positive NCLC. So this was a third indication. So the trial design was pure good. De novo metastatic stage 3B4 lung cancer, 3B4 lung cancer, paclitaxel plus ivonescimab or other arm tislelizumab. Though I thought why tislelizumab here? Probably both are Chinese made drug and now the flavor of season is Chinese. We have had toripalimab, so probably easier to get the drug. Ivonescimab versus tislelizumab. Primary endpoint was progression-free survival as per as independent radiology review committee. Everywhere in the previous it was investigator assessment and the key secondary endpoint was overall survival. This was a hierarchical study and we have seen in last ESMO the PFS was statistically significant, 11.1 versus 6.9, and so this was a final OS analysis. Now some important thing, it has not been mentioned, probably it should be patient above 75 were not taken in this study. Patient with the involvement of a major vessels were not taken. This was encasement. Patient with a massive hemoptysis or a major hemoptysis was not taken. So, but these were the 3 subset of patient. What I am underlined is they were taken, which it probably is a contraindication to give BEV also. So there were lesser number of patients, but in a trial analysis and above 75. So there will be a lot of things that we could have discussed later. Now, when you look into the main primary endpoint, at the end of 2 years, an absolute gain of 16.1%, if you say delta of 16.1, people were surviving at the end of 2 years, a 34% reduction in the risk of death. In terms of absolute quantum of benefit, it was 4.7 months. But I will like you to look into the control of 23 months in a squamous cell carcinoma with Pembro, you don't get it. So probably whether it has outperformed or not, you don't know. The forest plot suggests that irrespective of every subset, it benefits except for patient more than 65 years of age. So again, whether we should use it or not, although this was not a primary endpoint, so it was a post hoc analysis. We always talk about a drug, new drug, grade 3 toxicity 69, but I will be happy to see the discontinuation only 5.3. So probably the discontinuation rate is lesser and you have to manage it in a proper way, intelligent way. The commonest side effect was probably because of VEGF related adverse event. Proteinuria grade 3, 6.8, hemorrhage, hypertension and arterial thromboembolism, but it did not lead to discontinuation of the drug. So what it concluded was OS improvement, a quantum of benefit of more than 4 months with a statistically significant 34 reduction in the risk of death. Discontinuation, grade 3 were more or less equal, 69.5.8, but the discontinuation was only 5%, and probably now this is the new standard of care as a first line in China. So again, this is China. I'll tell you why China, because when you look into the study of Pembro in China, this was far better. So we need a global phase 3 study. The problem with this study is age 65 above, there was no advantage by giving this drug emanicimab. So probably we need to ponder whether these are the patients where there is a high risk, we know. So a lot of outstanding question, probably how much was the treat, what was the exposure compared to tislelizumab? What about old patient, why it did not benefit? Will the survival curve separate at the time of final? And can we interpret or extrapolate to the global population? This is what I'm telling. When you look into Keynote 407 on the right side and Harmony 6, Keynote overall survival was 17 months. But you see Keynote in Chinese, just before that, it was 30 months with Pembro. 1 year OS in Chinese was 79, 2 years was 57. So probably are these Chinese subset better where pembrolizumab works? So again, difficult to say, but last year we have a data clearly which says that ivonescimab is probably better than, but again, you need a global phase 3 data. These were the two plenary presentations. The third was, I'll tell you in a short, because of shortage, Crown 5-year amazing data. What about 7 years? So another 2 years are passed, and if you look into the thing, this is going from good to best, I can say. So Lorla versus Chryso, and there it was PFS by the blinded independent central review. And there now you look into 5 year here, 60 versus 8. So nearly 7 times more patients are still progression free at the end of year. The hazard ratio is 0.919. Now look into the 7 year from I'll go back 60 to 55 now. So in the 2 years, only 5% of the patient has progressed, and that too, if they say 7 number, 4 progression, she died unrelated to it, the ratio remains same, 0.19. So what it tells us is, are we looking at first time a chronic lung disease in ALK positive with this wonder drug called as lorlatinib? Now, the other amazing part is see the IC progression. At 2 years, it was 94. At 7 years, it is 92. Only 2% progress. So no new intracranial progression occurred after first 30 months of lorlatinib. Amazing. After 2.5 years, 0 patient who progressed in brain. Now, when you look into IC progression for those with baseline brain or without baseline, 4 only without baseline till at the end of 7 years. And this hazard ratio, I don't think you can get better than 0.04 and 0.03. So sustained plateau of response. I think so. IC Pro is something which is cherry on the cake, but the overall 7 years 55 is amazing. You have still not got the median PFS. Now, this is a difficult drug, whoever has used. There is neurological effect. I have struggled for edema. 2-3 patient has really. For those patients where we reduce the dose, again see the efficacy. Long-term efficacy is similar between with or without dose reduction within 26 weeks. So whatever dose reduction occurs early, if you have continued with the lesser dose, the outcome overall will be more or less the same. So if I have to conclude in a section, 7-year PFS 55, 7-year IC time to progression 92, no new safety again. I have not mentioned because of shortage of the ctDNA analysis shows no new emerging ALK resistant mutation. You know there are C797 and there are multiple. and earlier progressor had a high number of alteration and high tumor burden comparing to long-term response. So probably an indirect way to say it. The take home is, yes, at 7 years, we have a drug, magic drug, persistently controlled, systemically intracranially. And the most important thing I like is chronic condition. It may transform ALK into chronic condition. The last study is, this is a drug, if you have time, go through highlights of ESCO. There is a topic and this trial has been mentioned. So I made it a point to tell you sunvozertinib. It is an oral tablet for exon 20 insertion, which has the worst prognosis with a study called as WU-COM28 study. Now, if there are any students, this slide should be remembered, which I will not discuss. If anybody has to answer a exon 20, it started with FR, then 160 OC, then mobocertinib, then amivantamab, and now sunvozertinib. Now, these are the studies that has already been mentioned about papillon, chemo with amivantamab, and there was a mobocertinib. I'll tell you this study. So 1-to-1 randomization versus standard of care versus sunvozertinib, and the primary endpoint was PFS. Other endpoints were overall disease control. Now see this, overall 60%, PFS 10.3 months, duration of response 11.2, and PFS 21.7. Amazing data in this worst subset of patients. Grade 3 toxicity is 61%, but treatment discontinuation was 7 point only. So a safe drug, the toxicities were more of CPK elevation and a diarrhea, probably, which is manageable. So we have again a new standard of care, which is sunvozertinib. Remember, last year you had a EGF, ERB, where you zongertinib. Here you have sunvozertinib. Difficult to pronounce, but this is probably the best drug now. This is what I mentioned now. Look into the drug, compare it. ORR 73 versus 58, PFS 11 versus 10, duration 9 versus 11. So probably a new drug, and now you will have crowding of this drug in this difficult subset, and this drug is here to stay. A word only. Last, what is the best drug in your practice about atypical EGFR mutation advanced? We use afatinib and now OC plus chemo, but now this will change with the new data of amivantamab with chemotherapy, which was a secondary endpoint in the cohort C. 41 months was the OS. So probably when this drug lazertinib, I was told yesterday that this drug is coming in a month or two. So when this drug comes, probably this will become a standard of care for those exon 19 which are non-L858R or exon 19 deletion. So 3.5 years, the new standard of care. And last, the new standard of care, as all we know, is second line, which is the best drug in small cell, tarlatamab. That is Delphi 304 study. And the overall survival is 13.9 with or without brain met. So even if you have a brain met, it improves and equalizes outcome for patient impacted by brain met. So I have told you about 6 study, 2 plenary study, sunvozertinib, 7-year data, tarlatamab, and last but not the least is atypical EGFR mutation. I end my talk with one of my favorite slides, which I always quote, is of Socrates: the secret of change is to focus all your energies, not on fighting the old, but on building the new. I thank Ankit and Tarun for the kind invitation.
Thank you, Bharat sir. As usual, always it's a music listening to you, sir. Thank you. Thanks a lot for a wonderful discussion. I think we'll move on to our panel discussion. Dr.
Yes,
Deepak, we have our moderator, Dr. Deepak, a very dear friend, colleague, old colleague from my DM days. I welcome Dr. Deepak. He's a consultant, senior consultant medical oncologist at Care Hospital, High Tech City, Hyderabad. Welcome, Dr. Deepak. You can invite your panelists, please.
Thank you, Ankit sir. Thank you for your kind words, and thank you for inviting me for today's meeting. So I'll just invite the panelists. So Dr. Lalit Mohan Sharma.
Yeah, I'm here.
Yeah. Dr. Devesh Goyal.
So he is not joined. So he will
Okay.
not be
Dr.
joined.
Sachin Jain.
Yeah, I'm here.
Dr. Sachin Jain, yeah.
Yeah.
Dr. Jitendra. Jitu.
Yes, sir. Available.
Wonderful. Dr. Rahul Rai.
No, sir, Dr. Rahul Rai will not be there.
Okay. Dr. Abhishek Charan.
Hello, sir. Good evening.
Hi, Dr. Abhishek. So we don't have Dr.
Devesh and Dr.
Devesh
Rahul.
and Rahul.
Dr. Devesh and
Yes.
Dr. Rahul are not available, right?
Yes, sir.
Yeah. So, okay. So I leaked the secret, Ankit sir. Ankit sir asked me to continue the panel discussion for the next 45 minutes. And okay, on a lighter note, but yeah.
You can speak direct questions to Jitendra outside the panel.
He can
Yeah.
call me
So
anytime.
yeah. So, okay. So now moving ahead with what Dr. Bharat sir has elucidated, I think I'll make the panel discussion more simple and I'll just ask your opinions. Okay, there's no nothing right or nothing wrong. More than half of the drugs that have been discussed will not be available in India, at least for the next year or so, unless Glenmark or other companies try to launch them all quickly for us. So, keeping data in context. The first topic is ivonescimab plus chemo versus trastuzumab plus chemotherapy. Now, I always had my bets high on ivonescimab. I'm a very strong believer that this drug will bring change, at least in EGFR positive second line. I think this was one of the first drugs to show a significant overall survival benefit after amivantamab plus chemotherapy. So, in the context of ivonescimab plus chemotherapy versus tislelizumab plus chemotherapy in squamous cell, how many of you in the panel would use this in practice if the drug is available? Jitu, I'll start with you.
So see, means although one question is I don't know we have the answer for it. How anti-VEGF is useful in scammers, but the data is strong. If the drug is available in the same bracket, probably we are pushed towards using it because the data in comparison is strong. Although Bharat sir has told that probably the subset of patients which they see in China are different, but definitely in that subset also it showed benefit over Teslizumab. So if I can
Yeah.
write Teslizumab in my patient, probably I can write this drug also.
Dr. Lalit Mohan.
Yeah, unfortunately, my video is not working. I was trying for that, but I'm in agreement with the uses of this drug. Like previously, when IO was not available, we have used bevacizumab in a good number of patients in lung also. And of course, the main benefit was in the never smoker or the adenocarcinoma variant, which might be the biology per se also. But like this sounds to be a good combination.
Yeah. So this table reminds me of the Harmony study where it was compared in PDL1 positive patients where both squamous and adeno were taken. And there they compared single agent pembrolizumab versus single agent ivonescimab, and again statistically significant benefit in terms of PFS was derived, and also OS difference was statistically significant. Very characteristic of all the Harmony studies where they've characteristically mentioned what is the kind of squamous cell carcinomas. Even in that study population, they've taken squamous and adeno. Very clearly, they mentioned how many patients had cavity, how many patients had hemoptysis, how many patients had major blood vessel encasement, central tumor. So squamous cell carcinoma, they are always at higher risk of bleeding. So Dr. Sachin, uh, we all have this conventional teaching and conventional opinion about using VEGF inhibitors in squamous cell carcinoma because of these major reasons that they tend to have more hemoptysis and chance of cavitation and risk. So, Dr. Sachin, would this data convince you that this is the right approach and you would now move with the bispecific because it's not an entirely a VEGF inhibitor, it's a bispecific in principle. So, would you consider using this in your practice,
I think
Dr.
you have
Sachin?
told right that at present we are not using any VGF inhibitor like bevacizumab in the small cell carcinoma. Mainly these are for the
Yeah,
adenocarcinoma, as you told about all the
right.
cavitation and bleeding. But as we all always required some new medicines and some special medicine in the squamous cell carcinoma, like in the small cell also. So there are some new things in the small cell also, and this is I think it's kind of first in the squamous cell carcinoma. So I
Yeah.
definitely want to use this medicine and want to see effects personally and in practically.
Yeah. So this is one very interesting factor about this molecule that I was very much impressed. The PDL1 less than 1%. I think after the Checkmate 227, this is one of the first studies where the benefit of an IO or here a bispecific was statistically significant and clinically meaningful in terms of patients having PDL1 less than 1%. So, Dr. Abhishek, in the patient population with PDL1 less than 1%, Would you still be convinced with this data, or you would want an enriched population, or compare this with Nivo, EPIC, or a CTLA4 inhibitor?
Sir, benefit appears across PD-L1 group in this system,
Yeah.
but I believe maximum vaccine in PD-L1 low status or in those intermediate population. So for me, I would be convinced to use it even in low PD-L1 intermediate, because in higher PDN, if we have more than 50 and if one do chemo plus IO or single IO if more than 50. But in low PD-L1, I think we have very limited option, and IO won't show, though we can use, but won't show great result. So it will be a game changer in future, at least in the low PD-1 and intermediate form.
So this is one important question. Avoid ivonescimab any subgroups. Dr. Jitendra, your take on this?
Vaswani sir has already told any bleeding, hemopsis, abutting the vessels. So probably whatever bevacizumab contraindication is there, probably I
Abutting the
would like
vessels
to avoid.
yeah, almost encasement itself was there in a good chunk of patients. Yeah, yeah. So I think hemoptysis, again, history of hemoptysis was what characteristically Govind Babu sir used to ask in all the retinos and on squamous before we were planned to giving immuno or bevacizumab. But they did include this population of patients. And again, there are toxicities which are because of the VEGF mediation in the study population, but they are not strict contraindications for the rest of the audience. So yeah, as we can see here, a significant proportion of patients had hemorrhage and proteinuria, which are predominantly because of the VEGF-mediated toxicities. Yeah. Now, switching gears to Libretto 432. Okay, coming to the panelist. Today's date, you get a patient who is EGFR positive. So, Dr. Lalit Mohan, you have patients 1B to 3A EGFR positive. Would you use osimertinib in all your patients or not?
I will use.
Yeah. Okay. Dr. Sachin, if a patient is ALK positive in with a similar stage 2 to stage 3A, your choice of ALK inhibitors?
There are many, like the crizotinib is easily available, and nowadays Indian brands are also available, so it is affordable. So we can use it first, then in the second line and third line, the other medicines like seratinib and we can also use.
Yeah. So there is the ELINA data and also the recent data that got published in NEJM a couple of days back, 4 days back. The ELEVATE data with ensartinib in the specific population of patients again has shown a statistically significant benefit, again to the tune of 0.16 to 1.7 hazard ratios in terms of DFS. So now, what makes RED such a interesting, this study more interesting than the other three studies? So, Dr. Jitendra, your take on why Libretto 432 stands out compared to the other ELINA, Elevate, EDORA, Neo-EDORA studies?
Here, majority patient were able to take chemo, almost 90%. This is one thing. But my contention is means if you are giving new agent, if you have a started IO, then how I will change the things because reports takes 2 to 4 weeks to come. So that
Yeah.
is one thing.
Yeah. So, again, so 90% of the patients did receive this. One very interesting part about this was even consolidation treatments, local consolidation therapies like radiation were there more in patients with placebo than in the selpercatinib arm. But again, radiation was one local treatment that was advised in this study. But all three targetable mutations have shown consistent hazard ratios to the tune of 0.17 to 0.24. Now, with that context, Dr. Jitendra, would you consider using adjuvant TKIs in all your patients moving forward if a patient comes with a ROS1 positive in an adjuvant setting? Or
So
would you wait
earlier
for
I
the
have to
data to come?
say is means we should wait for the data. But obviously, if somebody doesn't want a chemotherapy, CTDN is positive, then probably I would like to add in non-available data set.
Dr. Abhishek, your take on this specific population of patients who are harboring actionable mutations in the adjuvant phase. Would you consider adding in most of these patients or limit yourself to only these three actionable mutations, EGFR, ALK, and RET?
Sir, I'll limit myself to only these three established trials and there, because I mean I don't know whether it will respond. I'll prefer to wait, and we have other options of using IO in these patients, so I'll
Yeah.
prefer to wait.
Exactly. So I just wanted to bring back this point of discussion. Not that though all the studies have shown a consistent benefit, we also have to remember there were multiple first generation EGFR TKIs that were evaluated, like the EVAN data, and multiple other studies that have not shown a PFS. Some have shown DFS advantage, but no OS advantage, and that is a consistent pattern. So till we have a phase 3 study like these showing dramatic responses, I think we should wait for data, and except for ROS1, most of the mutations we can get away by using immunotherapy in the perioperative setting in most of those patients. So now moving to sacituzumab tirumotecan. Now just a brief update. Sacituzumab tirumotecan is again one
Dr. Deepak,
ADC
just
that has.
sorry to interrupt. Just one information. Dr. Lalit sir is a very senior medical oncologist in our panel as a panelist, and we are very proud to have him here as a panel discussant. Just
Thank you,
that
Dr.
information.
So, Dr. Ankit, honestly, don't need that. In fact, the generation and the discussion and the era of all the new and new. So oldies are going old and old and old. So newcomers are always welcome. And we can see
No,
the
sir,
great.
but
Sir,
we are very
your
We
proud.
always
experience is
love
We are
newer
Dr.
very
than the
proud.
newer ones also.
Very proud to
Sir,
have you
your
here, sir.
experience is the newer one from the newer one also.
Thank you so much. Please carry on, Deepak.
So sacituzumab tirumotecan is a single agent ADC that has shown statistically significant benefit after ivonescimab. Actually, the highest, the longest PFS advantage in the second line post third generation EGFR inhibitors was seen with sacituzumab tirumotecan. It's a very potent ADC, and so this study evaluated the use of sacituzumab tirumotecan with pembrolizumab versus pembrolizumab alone. So again, a very promising drug coming from the Chinese neighbors. So again, this study was again very well discussed. Sir, Lalit sir, provided this drug is available, what do you think is the way forward in practice, sir? Do you think we can get away by not using chemotherapy in most of our elderly, frail patients and go with ADCs and immunotherapy?
I think what you are saying is sounds absolutely valuable and absolutely true. That in coming era we may forget the cytotoxic therapy, and after the addition of ADCs, the ADC plus IOs will remain, in fact, at least for a decade or so, I believe. So I'm a strong believer that yes, we need to have more and more of a targetable mutation, targetable drugs, and the era will be of combining the ADCs plus IO.
Yeah.
Over.
So, very rightly told, sir. See, across the study population, we can see the entire data is skewed towards the use of sacituzumab tirumotecan with pembro combination than using pembro alone. I think we would eventually move into an era where we are either using the bispecifics or these ADCs with immunotherapy in most of our patients, and this would be deriving a major benefit. Dr. Sachin, your take on the OS difference that we can see here? A staggering difference in terms of OS. The 1 year OS is 80.4% versus 70% approximately. So your take on this, Dr. Sachin?
11% to 12% difference in the OS. So it's a significant, I think, and the hazard ratio is 0.55. So it's a significant change in the OS according to this graph.
Yeah. So again, the toxicities are manageable mostly with anemia and marrow suppression. So I think if the drug is made available, it would be one of a practice-changing drug in our day in day out practice. So coming to use of amivantamab plus lazertinib. So the the entire space of atypical EGFR mutation management has for a very long time moved in terms of the structural classification. We have the PAC mutations, we have T790M kind of mutations, we had the classical EGFR, exon 20. These are the four kinds of structural mutations that we see with EGFR. But amivantamab being an extracellular moiety, which targets the extracellular moiety of EGFR, has shown consistent benefit in the classical EGFR mutations, in the T780M population, in also specifically in the exon 20 and in the PAC mutations. So if the drug at least in patients with atypical mutations, how many of you would consider using this than our second generation drugs like afatinib and dacometinib? So, Dr. Jitendra.
Sir, if only problem with this combination is a toxic regimen to give. So the patient is
Yeah,
fit, good PS, we can use it.
yeah, yeah. So, Dr. Abhishek, your take on using this combination in most of our patients?
Yes, sir. I think it will be a, I mean, good thing to use. I mean, in future, and it will be a good thing, sir.
Yeah,
At least in rare mutation where it won't be, I mean, we won't be having much of the response with OC and other TKS. This will be a good combination.
yeah. We can use the skipper regimens. We can use the Novax to decrease the risk of DVTs, and I think as we use this drug more often in the second line setting in the classical EGFR mutations, we can end up using them in most of our patients because of the staggering difference of 41 months with the use of afatinib in atypical mutation. The median OS was 19 months. So we are literally doubling the survival of our patients with such atypical mutations, which is almost close to what we see with the FLORA 2 data, which is around 47, 48 months. I think the space of even this atypical EGFR mutations is moving at a much rapid pace. So yeah, so Dr. Ankit, I like I promised you, I've completed my panel discussion well in time, and I think like all the panelists have rightly pointed out, Harmony 6, which is laying the pathway for bispecific monoclonal antibodies, is now entering into the first line, and I think the bispecifics like the ADCs are here to stay and will drive a significant benefit. And again, one more bispecific, that is amivantamab, is showing consistent benefit across all structural types of EGFR mutation, and Liberator 432, like the ELINA, like the Elevate data, is showing that using adjuvant TKIs would significantly improve the outcomes of our patients. Thank you. Over
Thank
to
you,
you,
sir.
Dr. Ankit.
Thank you. Thank you,
Thank
sir.
you. Thank you, Dr. Deepak. Thanks a lot. Thank you, Lalit sir, Sachin sir, Dr.
Thank you.
Abhishek, and all the panelists for a wonderful discussion. Thank you. Uh,
Thank you,
can we
sir.
move on to our next session, please?
Yes, sir. So moving forward, the next session is sponsored by JNJ. And for this, I would like to invite Dr. Pulkit Nag, sir, consultant medical oncology at Apex Hospital, Jaipur, for the talk on A Tale of Two Stories, Redefining Treatment Outcome with Mariposa 2 and Papillon. Over to you, sir.
Very good evening to everyone, and I congratulate Dr. Ankit sir for his first ever webinar. And without wasting any time, let's move ahead with the presentation. I'll share my own slides. I hope it's visible.
Sir, it's coming. Yes, sir. So just make it full screen.
Yeah, I think I'm not able to see it. Is it full screen now?
Yes, sir.
Okay. So the topic is A Tale of Two Stories, Redefining Treatment Outcomes with Mariposa 2 in Papillon, and I'll thank Janssen and Jetser for providing me the slides. So we all know that there is a current outcome for advanced NSCLC whether there is a room for improvement or not. So acquired resistance to treatment is a major barrier to improved outcome. So we know that real world 5-year OS rate following treatment with first line osimertinib remains low. I think we all know in a clinical practice that it has become 18%. And you can see by the diagram that the red one are the survivors and then gray one are the non-survivors. So over the years, it's only 18% is the survival rate of 5 years. So patient experience disease progression and ultimately die of lung cancer because of resistance to treatment. And this is important because avoidance or delay of acquired resistance has a potential to improve outcome, maximize duration of treatment, improve median PFS, and also improve median OS. So like most patients treated with first line EGFR, we know that has a median PFS of 9 to 15 months. And with third generation EGFR TKI, now we have 19 months. But all of them develop progressive disease due to acquired resistance that is primary by EGFR, or there are some other off-target mutations. So if we talk about osimertinib, which is the current standard of choice in first-line settings, we know that the PFS one is 18.9, and then it is PFS two is 15.2, and median OS is 38.6 months. So although osimertinib is effective in this patient group, tumors eventually become resistant, and there is progression of disease. So what are the acquired resistance? Why it is like that? Because to osimertinib, the acquired resistance is highly heterogeneous. One, we have the on target, that is EGFR mutation up to 10%, the cell cycle up to 10%, and we also have some off-target mutation like MET amplification, which is the highest number of 15%, and MAPK PI3K pathway, that is 13 to 14%. So all these resistant mechanism leads to the increased tumor burden and finally progression of disease. So if we look at the on the right-hand side of the diagram, the MET amplification was the most common resistant mechanism for osimertinib early progression. And EGFR C797X acquired resistant mutation emerges as the most common mechanism normally after 12 months of treatment. So the patient is surviving for 1 year, and if there is resistance, then this resistant mechanism has been found out in the maximum incidence. So I think we have discussed that acquired resistant mechanism are broadly similar between both osimertinib plus chemo and osimertinib monotherapy treatment arms with no novel resistant mechanism identified. So how do we overcome the resistance? If there is on-target inhibition, there are some trials. If there is off-target inhibition, VEGF, anti-PD-1, monoclonal antibody plus chemotherapy. Now we have ivonescimab plus chemotherapy. If the third generation TKI plus combine on and off-target inhibition, we can add some MET inhibition with osimertinib like tepotinib and savolitinib. Also, there is option of adding amivantamab plus chemotherapy for MET inhibition, because we know that they work as a dual antibody drug conjugate and targeting tumor-associated antigen. We have HER3 ADC like panitumumab deruxtecan, MET ADC, and we have TROP2 ADC like datopotamab deruxtecan. So testing for resistant mechanism and assessing the possible therapeutic options available upon progression is critical to define the optimal management in the future management of lung cancer. So platinum-based chemotherapy is also a standard of choice with an overall response rate of 27%, PFS of 5.5, and OS of 14.7 months. But it's like platinum-based is the current standard of second-line treatment of choice, and it has demonstrated clinical benefit in this patient group. So now, if we talk about progression post osimertinib, then amivantamab addresses several problems of the resistance, bias extracellular binding to EGFR, which mitigates the EGFR dependent resistance mechanism, extracellular binding to MET, which blocks the bypassing the EGFR independent resistance pathway. Counter compensatory mechanism depend on crosstalk between EGFR and MET by binding to both pathways. And it has been proposed that amivantamab in combination with chemotherapy could improve outcomes in intracranial METs versus chemo alone, because I think it's one of the mechanism of amivantamab helps in crossing the blood-brain barrier. So three distinct cellular mechanisms of action achieve a broad spectrum of activity against tumors which can be highly heterogeneous. So key takeaway, more than equal to second-line common EGFR mutant NSCLC, overcoming resistance constitute a major unmet need. NGS testing should be performed upon progression. Most patients develop resistance to first-line EGFR TKI and experience progression. The real-world studies have shown that chemotherapy demonstrated a PFS of 4.7, and management after progression depends on patient, disease, and treatment-related factors. So targeted therapy may help improve outcome for patients with common EGFR mutant non-small cell lung cancer upon disease progression. So now we're going to talk about the two stories. The first one is amivantamab plus chemotherapy with or without lazertinib versus chemotherapy in EGFR mutated advanced NSCLC after progression on osimertinib. So this is a second line therapy that is Mariposa 2. It's a phase 3 global randomized controlled trial. And we all know the inclusion criteria. EGFR exon 19 deletion or LH58R mutation was included, progression on osimertinib, and the stable brain mets were included. And these are the comparative arms: amivantamab, lazertinib, chemo, only chemo, and amivantamab plus chemotherapy. Dosage, we all know that more than 80 kg, 1750 mg or 1400 mg for the first 4 weeks, and then 1750 mg every 3 weeks. Lazertinib 240 mg OD, starting after the completion of chemotherapy if it is given with the chemotherapy, and chemotherapy dosing we all know. So Mariposa 2, like Mariposa, is a unique randomized controlled trial requiring brain imaging in all the patients. That is, MRI was done at the baseline. This was the demographic and baseline disease characteristic. So a significant number of patients we can see had the brain match in this criteria. So the first and the only regimen with the benefit of significant PFS versus the standard regimen, that is a significant 52% reduction in risk of progression or death versus chemotherapy alone. That if we give amivantamab plus chemo versus chemo, then obviously the results are better. I already had a patient who has completed almost 3 years on this. Then we have current PFS benefit of amivantamab across all the subgroup. We can see on the forest plot that almost all the subgroup is benefited from this combination. And the progression-free survival, if you talk about Asian patients, then significant 46% reduction in risk of progression or death, as which is consistent with the overall population. And with the combination also develop a higher response rate of 64% versus 36% receiving only chemotherapy. So almost the double. It also demonstrated a wonderful intracranial PFS benefit, that is 45% reduction in intracranial progression or death versus chemo alone. So early separation and sustained CNS protection. Addition of ME demonstrates significantly improved intracranial PFS, and amivantamab plus chemo showed intracranial progression-free survival benefit among patients with a history of brain mets and no prior brain radiotherapy. So by omitting patients with prior brain radiotherapy, we are able to better isolate intracranial activity attributable by amivantamab. So I think this is also a wonderful effect if I combine amivantamab and chemotherapy. Also, amivantamab plus platinum-based chemotherapy demonstrate a favorable trend towards OS benefit versus platinum. So at the time of cutoff, the median follow-up of the study was 8.7 months. And we can see the separation of the curve maintaining till around 15 months. So early OS curves showed a linear separation, and amivantamab plus chemo demonstrate prolonged progression-free survival after the first subsequent therapy versus platinum-based chemotherapy, that is PFS2, and median PFS2 of 13.9 months is maintained by the combination versus 11 months if only chemo is given. That is progression post-chemo. So we all know the adverse effects. I think the amivantamab chemotherapy had higher rate of grade 3 adverse effect, and but leading to death were very low, and discontinuation of all agents due to treatment-related adverse effects were 2 to 8%, and majority were infusion reaction or dermatological reactions.
Sir, kindly conclude in next 2 minutes.
Okay, fine. So we know that the combination has higher amount of neutropenia, venous thromboembolism, and these are the various side effects. So 52% reduction in risk of death and greater PFS and PFS2 benefit. We all know that is included in amivantamab and NCCN guidelines, also included in ESMO guidelines. The next trial is amivantamab plus chemo versus chemo in EGFR exon 20 insertion. That is Papillon trial. And this is a de novo EGFR exon 20 insertion mutation. This is the randomization. This is the demographic clinical characteristic. And we can show that amivantamab chemotherapy reduces the risk of progression or death by 60%. So 11.4 versus 6. Almost double PFS, great disease reduction, and difference of PFS rate is almost 10 times. That is 31% versus 3%. The benefit was maintained across all the subgroup. And there was a great benefit of overall 66 versus 43%, 1.5 times. Duration of response was also maintained wonderfully by amivantamab plus chemo, doubles the duration of response. PFS after first subsequent therapy was also longer PFS2, supporting the first line use of amivantamab plus chemo. So I think all these show that how wonderful in EGFR exon 20 insertion, the first line amivantamab plus chemo has worked. And I'm just skipping the slides. As far as safety profile is concerned, managing the infusion reaction, managing the dermatological reaction are the important point. So with the two most important is the skipper study, starting the DEXA 2 day, 1 day before, helps in preventing the infusion-related reaction, and the cocoon study, preventing the dermatological reaction, that is prophylactic oral antibiotic, clindamycin lotion, moisturizers, and chlorhexidine solution also help in preventing a lot of dermatological side effects. So this was the last slide, that skipper protocol for infusion reaction of oral DEXA, venous thromboembolism prophylactic for the first one, oral anticoagulant, and cocoon trial, the oral anticoagulants, topical lotion, and chlorhexidine on the fingernails and toenails. Thank you so much.
Thank you, Dr. Pulkit. Again, wonderful hearing you. I remember the first time I was planning to use amivantamab, I called you and spoke to you. यार भाई बता दे कैसे यूज करना है. Thank you.
Yeah.
Thanks a lot. Yeah. Thank you.
Thank you,
Thank you.
Ankit. Thank you so much. And thank you, Johnson and Johnson, and thank you, organizers. Thank you.
Thank you, sir. Thank you so much for the wonderful talk. Moving forward, I would like to invite Dr. Tarachand Gupta, Senior Consultant Head and in charge of Geriatric Oncology at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. The session is sponsored by Zydus, and I would like to invite Dr. Tarachand for the talk on role of nivolumab in SCHN carcinoma, innovation to impact. Over to you, sir.
For inviting me, and I'm just opening the slides. My screen visible?
Yes, sir.
Okay.
Yes, sir.
So we are discussing the role of nivolumab in squamous cell carcinoma of head and neck involving to impact. So now the Indian version of nivolumab is available in the name of Ista right now from the Zydus. So is the pioneer in the biosimilars of MAPS right now. So this is the journey of development, a 10-year development journey where the clonal development started in 2015 and 2017 biosimilar assay against 2019 DVT1 submission, tox approval in 2020, and then 20 tox completion, C5 submission of phase 3 clinical trial, submission of MA application to DCGI, NAV approval, and legal journey. So Tista contains the same active drug substance like the innovator glycosylated human monoclonal antibody of Ig4K isotype composed of 1308 AA MW143 kilodalton approximate, expressed in the genetically engineered CHO cells like the reference product, developed with the same pharmaceutical composition as the innovator. The approved strength same as the innovator, like 40 milligram, 4 ml, and 100 milligram in 10 ml. 10 ml route of administration is same, the intravenous. So, nivolumab, squamous cell carcinoma of the head and neck cancer, nivolumab as a monotherapy is prescribed for the treatment of recurrent or metastatic squamous cell carcinoma of the head and neck in adult patients with disease progression on or after platinum-based therapy. This is the CheckMate 141 study that where the nivolumab first established after in a recurrent head and neck setting, and a platinum resistant or platinum refractory stratification factor was the prior cetuximab treatment, and patients were randomized 2-1, the more in the experimental arm, nivolumab 3 milligram per kilogram IV 2 weekly versus investigators' choice that may be methotrexate, docetaxel, cetuximab. Those were the standard of care at that time. Primary endpoint is the overall survival, and other endpoints were the progression-free survival, overall response rate, safety, duration of response, biomarkers, and quality of life. Sustained overall survival, and we can see over the time, we can see first, if at the 6 month, it is the 56.5% versus 43, that is 13% difference. And it is the at 12 month, it is the 13.6 versus 19.8%, around 14% difference at And at 2 years, it is 6 versus 16.9%. So that means every 6 patient was alive in a study in the favor in nivolumab and comparison to the average 16 patients. So double the duration of response, 9.7 versus 4 months. So median time to response was similar between the nivolumab and investigator choice. This improved the overall survival independent of PDL1 status. So in PDL1 less than 1% is still 6.5 versus 5.5. And in PDL1 positive patients, it is 8.2 versus 4.7 months. Nivolumab demonstrated survival benefit in both subgroups. Was more pronounced in patients without prior cetuximab, although it was significant also in the cetuximab arm versus 7.51 versus 5.1, and in the without prior cetuximab, it was 8.2 versus 4.9. So key takeaways from the checkmate 141, nivolumab delivers a clinically meaningful survival advantage, improving median OS. Nearly doubling of median duration of response was consistently maintained at 12, 24, 36 versus chemotherapy. Patient achieving CRPR experienced transformational outcomes. Patients without prior cetuximab had better survival outcomes, and survival gains were achieved with a favorable tolerability profile. So this is the low-dose immunotherapy in head and neck cancer practice-changing study and blockbuster from the Indian scenario. It was by the Dr. Vijay Patil. This was a phase 3 superiority study. Adult patients with recurrent or newly diagnosed advanced head and neck squamous cell carcinoma, both were taken, not for first line, second line. And nivolumab 20 mg flat dose every 3 weeks versus oral methotrexate 9 mg per meter square once a week, celecoxib 200 mg twice daily, and erlotinib 150 mg once daily. 151 patients were randomly assigned, 75 in TMC and 76 in the TMC arm. Primary endpoint was 1 year OS. Baseline characteristics were well matched with relatively younger population, with a male predominance as the head and neck cancer dominates in the males, with good performance status 0 and 1. Tobacco use was quite common in oral form. It was 73.3%, and smokers were 10.7%. With a previous treatment, 62.7% patients had the previous treatment, and 37% were newly diagnosed. And focus surgery and radiation were received by 25.3 and 29.3% of the patients. Previous treatment was the platinum, around 8%, 9.2 in the investigator arm, and taxane 1.3%, and taxane and platinum 45.3 versus 50. And there was no treatment was taken by 47.7 versus 39.5. Patients were having metastasis around 12% in the control arm, and investigator arm, it was around TMC arm, it was 10.5. So no, and 88% around patients were not having any metastasis. PDL1 score, still we can see there are 12 versus 7.9% unknown status, and it was negative in 16 versus 10.5. And 1 to 50, 42.7 versus 57.9, and more than 50, 29.3 versus 23.7. So low dose nivolumab led to the improvement in the 1 year OS from 16.3 to 43.4. The median OS 6.7 month versus 10.1 month. This is the flagship proof of concept that the very small dose nivolumab can deliver benefit when paired with rational backbone metronomic therapy or immunomodulatory chemotherapy contact. The rate of grade 3 and above adverse events was 50% and 46.1% in TMC and TMCI arms, respectively. So 4-year landmark survival analysis of low-dose nivolumab added to metronomic chemotherapy in advanced head and neck squamous cell carcinoma, a phase 3 randomized trial. It was TMC plus low-dose, median overall survival 9.48 versus 6.7, and 6.7 month OS hazard ratio 0.70 with a 30% reduction in mortality risk. P-value was also significant. Median progression-free survival 6.63, PFS hazard ratio around 0.66. 3-year overall survival was 13.6 versus 5.1, and 4-year overall survival 7.8 versus 5.1. hazard ratio 0.70, 0.66. The combination therapy reduces the risk of death by 30% and the risk of disease progression by 34%, indicating a durable survival benefit. So to conclude this, low-dose nivolumab combined with metronomic chemotherapy improves the OS, PFS, and long-term survival in advanced head and neck squamous cell carcinoma, offering a cost-effective and scalable immunotherapy options, especially for resource-limited settings. Ultra-low dose immunotherapy plus oral metronomic chemotherapy versus paclitaxel carboplatin in platinum-sensitive recurrent or metastatic head and neck squamous cell carcinoma, a randomized phase 3 trial. So low-dose nivolumab versus platinum chemotherapy. This was the ASCO 2026, where the TMC arm was the paclitaxel 175 milligram per meter square plus carboplatin, and TMCI oral methotrexate plus nivolumab. The primary endpoint was overall survival. 53.4% overall response rate was 53.4% versus 24.1%. 1 year was 46% 23. Median was 10.3 versus 6.2 months, and median PFS 5.5 versus 2.7 months, and fewer grade 3 or more adverse events. TMCI significantly improved survival outcomes and response rates while reducing severe toxicity and preserving quality of life compared with PVC. Neoadjuvant nivolumab plus carboplatin and paclitaxel in patients with locally advanced resectable squamous cell carcinoma of head and neck, a phase 2 single-arm trial, where the pathological and radiological response at the primary site after neoadjuvant treatment for 33 patients, that means 45% having a PAT-CR at the primary site. All PAT-CR patients who received the recommended adjuvant therapy had neither disease recurrence nor death during the study and follow-up period. So to conclude, this phase 2 trial of neoadjuvant nivolumab plus carboplatin and paclitaxel in previously untreated, locally advanced, unresectable squamous cell carcinoma of head and neck was well tolerated and reached its primary endpoint of HCR at the primary site. If phase 3 confirmatory study is warranted in the advanced resectable HPV negative squamous cell carcinoma of head and neck. Post-platinum recurrent metastatic squamous cell carcinoma of head and neck, only nivolumab and pembrolizumab have demonstrated OS benefit at standard of care, nivolumab survival benefit independent of PD-L1, cleaner biomarker agnostic narrative. First line recurrent metastatic squamous cell carcinoma of head and neck, pembrolizumab dominates with PD-L1 driven. Curative intent, post-operative high risk, nivolumab is the first IO to show DFS benefit added to cisplatin. And TMC low-dose nivolumab data, ultra low-dose nivolumab plus metronomic chemotherapy, 1 year was 43% versus 16%. Thank you.
Thank you, sir. Thank you for the excellent talk. Any
Thank you,
questions?
Tarajan sir. Thanks a lot for your wonderful discussion. Do you frequently use low-dose nivolumab, Tarajan sir?
Nowadays, I think low-dose nivolumab concept is obsolete because of the low cost of standard dose. Now the Tista is available in 13,000 and 40,000 MRP. So I think it is lesser than a cost of chemotherapy.
Okay, perfect.
And when you use the PEP, it is quite cheaper.
I agree. I think interesting concept of low dose, but I think now with the availability of
एक चीज लेकिन फिर भी 30,000 क्रॉस करेगा आप जैसे में पैनल बनाना पड़ेगा
नहीं
आप ही ने गाइडलाइन बनाई है आप ही ने गाइडलाइन बनाई है
नहीं बोल रहा हूँ आज पेशेंटों ने नैप पैक्लिटक्सेल के लिए मेरे से मांगा तो मैंने पेशेंटों को मेरा डिस्चार्ज टिकट पकड़ा दिया मैंने ये जाके अप्रूवल ले लो मैं बना के देने वाला नहीं हूँ मैंने कहा हर कीमो का लेटर बना के देने वाला नहीं हूँ वीकली ये डिस्चार्ज दे दो ये प्लान लिखा हुआ है डिस्चार्ज पे गो अहेड अगर दे देते तो ठीक है नहीं वही लगवा लेना
perfect. Okay. Thank you, Tarajan. Thanks a lot. Yeah, thank you for wonderful discussion. Can I share the slides? Yes.
Yeah. So, sir, next for the next talk, and the last one, which is sponsored by INTAS, I would like to invite Dr. Ankit Agarwal, who is consultant medical oncologist at Gitanjali Hospital, Udaipur. Over to you, sir, for the talk on next gen IU.
Thank you. Are my slides visible? We'll go ahead with the slides in 10 minutes.
Yes, sir, it's visible.
Okay. So coming to the last discussion of today's session, and I think all the faculties have done a wonderful job. Moderators, panelists, and the speakers. I think it was a brainstorming 3 hours of discussions. We'll wrap it up in the next 10 to 12 minutes. So coming to the last discussion is next generation immunotherapy, that is serplulimab, and basically it has a global footprint that has been approved globally in around 50 countries and various indications coming from lung cancer, both squamous, non-squamous, extensive stage small cell. We have esophageal squamous cell carcinoma where it has been approved, and also in gastric cancer in both neoadjuvant as well as adjuvant setting. I think it is a very broad landscape of approval, and one interesting trial that they have been doing and the enrollment has completed is the Astride study, where they are directly comparing serplulimab with the already established atezolizumab in extensive stage squamous cell lung cancer. This is the trial result that we look forward to. I think in the next 4 to 5 years, we should be able to tell what exactly is a better immunodrug to be used in these type of patients. But what is different in Serplulimab? Why do we need to know about Serplulimab? Why do we need to use Serplulimab in our patients? So basically, the main difference is the binding affinity. It has 10 times higher affinity than nivolumab and 3 times higher affinity than pembrolizumab to the PD-1 receptor. It is an anti-PD-1 monoclonal antibody of IgG4 subclass with a higher affinity as compared to nivo and pembro. Also, in contrast to pembro, it binds the same epitope, but the approach to it is at a different angle because the chains contribute differently. And having a structural and spatial analysis, it has more complete binding and blocking the PD-1 target as compared to other PD-1 inhibitors, and a slower dissociation rate leading to an early T cell activation. It has a more robust and rapid PD-1 internalization than nivolumab, and also because of other mechanisms, also the T cell lysis is lesser with serplulimab as compared to other immuno-oncology drugs, other PD-1 inhibitors. We have the Astrum 005 data that has led to the approval of serplulimab in extensive stage small cell lung cancer. This is the trial design that led to the approval. It is a global phase 3 trial which was randomized and double blind, wherein histologically or cytologically approved extensive stage small cell lung cancer patients were randomized in the first line setting in a 2:1 arm. The total number of patients were 585. They were randomized to serplulimab with chemo versus placebo with chemo, and and then in the serplulimab arm, serplulimab was given at a dose of 4.5 milligram per kg every 3 weeks, and then it was given as a maintenance dose until disease progression. The primary endpoint was overall survival. Interesting point to look for is around 25% of these patients had liver metastasis, 13% of the patients had brain mets, and more than 80% of the patients had PDL1 negative status, that was TPS less than 1%. And the result shows that at the end of 54 months of follow-up or 4 years of OS, 21% or 22% of the patients were alive in the serplulimab arm as compared to 7% in the chemo alone arm, suggesting 3 times better survival rates as compared to those patients who did not receive serplulimab, with a hazard ratio of 0.6, a 40% reduction in the risk of death as when serplulimab was compared to placebo. The median OS was 15.8 months versus 11 months when serplulimab was compared to the chemo alone arm. Forest plot says that OS benefits was consistent across all the subgroups. Even those patients who had brain mets and liver mets, they did have a good benefit when serplulimab was added to the chemo arm. Interesting to look at is a TPS score of less than 1% also had a benefit when serplulimab was added to chemotherapy as compared to the no serplulimab arm. Secondary endpoint also suggested a significant prolonged median progression-free survival. Median PFS was 5.8 months versus 4.3 months, a 63% reduction in the risk of progression when serplulimab was compared to the placebo plus chemo arm. Coming to the snapshot trials in first line extensive stage, we have the Astrum 005, we have Empower 133, and the Caspian trial of durvalumab. The median OS 15.8 months was numerically higher than atezolizumab, which showed a median OS of 12 months and 12.9 months in the durva arm. Although cross-trial comparisons are difficult to interpret, but still with the data that we have in front of us is the hazard ratio of 0.61 that was the lowest in serplulimab trial as compared to atezolizumab with and durvalumab trial. 4-year survival rate of 21.9%, and here in the atezolizumab trial and the durva trial, 2-year survival was close to 22%. Overall response rate 68.9% in the Astron trial as compared to 60 and 67.9% in the Empower 133 and Caspian trial. Also, the ESMO MCBS scale, the magnitude of clinical benefit scale, has said that serplulimab scores over atezolizumab and durvalumab. I think primarily it might be because of the cost effectiveness of serplulimab as compared to atezolizumab and durva. Updated safety results, overview of the treatment emergent adverse effects, they were well manageable, and the expected side effects of immunotherapy were seen with serplulimab, which were manageable. So this is the Astrum timelines. In September 2022, the Astrum 005 led to the approval of serplulimab in extensive stage small cell lung cancer. January 24, the Astrum 004 led to the approval of serplulimab in squamous non-small cell lung cancer. In non-squamous non-small cell lung cancer, December 25, the Astrum 002 trial came up, which was published in Lancet, and also it was presented in ESMO.
So, Dr. Ankit sir, this is a great presentation. Just last 1 minute to conclude with the
Yes,
key
definitely.
message.
We have just 3 more slides, important 3 more slides. So in February 23, we have in esophageal cancer and perioperative gastric cancer, it got approved in October 25. I think the landscape of serplulimab is increasing, and we have a very good data. Also, there are trials wherein the enrollment have been completed in localized small cell lung cancer, in renal, in pancreatic cancers, and colon cancer. The Astrum 015, the metastatic colon cancer, we are waiting for the data. So serplulimab has a unique mechanism of action, and it has the highest ESMO MCBS score of 4 for small cell and esophageal carcinomas. Perioperative treatment of gastric cancer, it has it's been approved, and we are waiting for the results of the colorectal cancer trial also. I thank all my colleagues for a wonderful discussion, and taking out their time after a hectic Monday day. I thank Tarun and his team for an amazing management.
Ankit is asking to Ankit, please stop, please don't overshoot. This is the so fear about Ankit that Ankit himself, it's like the Mamta Banerjee who is protesting against the Mamta Banerjee.
Thank you, and I'll see you tomorrow. I'll see you, Tarajan sir, tomorrow again.
Okay.
So, good evening, and thank you, Dr. Ankit sir, for giving this great opportunity. Yes, of course, Dr. Tara sir, you're there tomorrow as well, and we will definitely hear from you. So, on behalf of the organizing team, Dr. Ankit, a big thank you to all the faculty who have joined today, all the students have joined today. Till then, we meet again. Thank you from all of us. So, thanks, Pooja, Daud, and Manya, and the entire organizing team for giving this opportunity. We see you tomorrow again at the same time, 6:30. Thank you
Thank
so much
you.
and good
Thank
night.
you. Good night.
Tech team, please close the session. Thank you so much.